días, ¿se escucha?
Good morning. Can you hear me? Good morning, everybody. This is the last working day of our regional PHC forum. As every morning, we need to remind you of a few basic things. You have headsets for simultaneous interpretation outside, and for those who came on the second day, part of the organization and our agenda for today. Today, we will have 2 parallel sessions during the morning. We even have people in the other room waiting. And during the first part of the morning, we'll complete the axis of innovation implementation, which started yesterday. These sessions will work until 10. We'll have a break in both rooms, A and B. In this room, we'll have the innovation session, integration of care during the life course, and in the second floor room, interprofessional team organization for PHC. An important matter to take note regarding today's agenda is that after the workshop, we'll have the workshop sessions, one on tools and experiences. For that, we'll work again throughout the day in the 2 rooms, with the exception of the last workshop that will be in this room. And we'll go back to the plenary format. So we'll have the last workshop and the closure of the forum at 5:30 with participation of Mr. Barbosa, the director. Well, so I'll tell you what we'll have this morning between 10:30 and 12:30 in room A. We'll have workshop 1, technical cooperation tools to advance in PHC, and in room B, workshop 2, digital transformation in PHC, the Telesalud case. A last reminder is that at midday we'll have a parallel event on invitation. It's an informative meeting, a dialogue on health in the Americas within the framework of the Summit of the Americas. This will be held at the Radisson Victoria Plaza Hotel at 12:30, and we'll have their representatives from member states on invitation. Without further ado, time flies. Let us then start. I invite my colleague Enrique Vega to chair this session.
Buenos días.
Good morning. Thank you, Ernesto. I always start apologizing for the translators because I don't speak Spanish, I speak Cuban. And that's always difficult for them, but I'll try to be as articulate as possible. Well, I'm very happy to share with you this space. Our work team in Pajo has been and is a major challenge to define how we could ultimately provide the health people need during their life course. Ultimately, and this has been clear these days. We're living in a world with a very special dynamics. That is, the world in which we live, and particularly in our region, is experiencing extremely fast transitions of all sorts. And for the first time in the history of humankind, the life course, the social course, is much faster than the life course of one generation or person. So these transitions that are of all sorts, as you're aware, demographic, epidemiological, social, economic, technological, communicational, and so on, somehow impact and shape the manner how our people perceive health, care for their health, and focus health on different needs. So understanding this context is important to provide this in the most effective and efficient manner possible. People have mentioned the demographic transition several times. This significant and abrupt increase of life expectancy, longevity of our people. In the last part of the past century, life expectancy in the region increased 20 years. The last time humankind 20 years needed 20 centuries, and only in half a century it increased 20 years of life. For the first time in the history of humankind, 5 generations lived together at the same time in the same time space period. So we have very different contexts, generations that are extremely different in the manner how they perceive the world, but that in turn are closely related and interconnected. The decisions taken by one with their lives and health generally not only impact on them, but also on many others. For this transition that is so important, that is accompanied by extremely fast population aging and very deep and separate from social and economic development for the first time in the history of humankind, we must add the epidemiological transition that, well, you're experts on that. You know how that behaves.
But I dare remind you that it doesn't just mean a predominance of chronic, non-communicable diseases above communicable diseases, but it also means a transition of the disease burden from a predominance in the impact of mortality to the predominance of disability. And so, although we still have an important debt on early death, in most cases, the most important concentration of public health needs are expressed in the appearance of an ever-growing gap between life expectancy and healthy life expectancy. In this region, it is 11 years now, more important in females than males, and it increases in those countries where life expectancy grows more. So that gap summarizes the challenge to public health, to modern public health. The chronicity of our disorders, longer and longer times are lived in the presence of one disease, progressively this loss of capacities, disability, and eventually depending on somebody else's care. In that concept, it is ever more clear not only what has been clear for us in public health for many years, which is social determination of disease and of health, and after COVID it was clear the capacity of health as a resource for development to determine social development, but also individual human development throughout the life cycle. In that context, our team has thought for some time now that the challenge to PHC of satisfying these needs to provide health and well-being to all ages means important dimensions that we have to reconsider. The first one is the need to use health as a resource, to use health as a tangible resource that is generated throughout life. You are born with a certain genetic potential, but it is really generated and maintained and sustained as long as possible through life. The need for this to become a collective construct between state, society, and the individuals. The need to manage diseases in a more anticipated manner, more comprehensive, more dynamic, more continuous in the context of the expansion of life. Third, the capacity to create environments and interventions that make true multi-sectoral participation in the development of these environments and processes. And fourth, how do we strengthen agency of individuals, families, and communities? It is ever more necessary for the individual to be a participant, the individual, family, and community to be an active participant in this process of health generation, that we don't just see them as a patient or as a group of individuals that us, as people in the health sector, are leading towards a health result, but that they are an active participant and continuous participant in this process of health generation. In order to discuss this, we have gathered here a panelist deluxe. So I invite you, I will name you, and I invite you to come to the rostrum. We have Maria Soledad Martinez. Maria Soledad is a surgeon, Master in Public Health from the University of Chile, PhD on Health and Policy Analysis from the University of Berkeley, Assistant Professor of the School of Public Health in Chile. She has been Director of PHC at the Ministry of Health in Chile till a few weeks ago, and she is now Director of the Control and Disease Prevention Division at the Ministry of Health. We also have here Jeremy Veilat. Jeremy is Senior Specialist of Health for Latin America and the Caribbean in Practical Global Health at the World Bank. He was Executive of Medical Care in Canada and France with much experience in service delivery, research and analysis of health systems. He has a PhD in Public Health and Health Systems Research from the University of Amsterdam in the Netherlands, and a Master's in Hospital Administration from the School of Advanced Public Health Studies in France. We also have Ana Castillo Lesca. Ana is Senior Officer of PetLab, the Laboratory of Innovation of the IDB. She has more than 20 years professional experience in management of innovation projects in the public and private sector. Her work at IDB Lab has concentrated on the development of entrepreneurship ecosystems at the early stage with technological advances responding to the needs of vulnerable population in Latin America and Caribbean. She is co-author of several publications and with the IDB group since 1999 and 2022. She collaborated with the Agenda for an Economy. And last but not least, my friend and colleague Gabriele Sola. Gabriele is currently head of the unit of health promotion and social determinants of health of PAHO. She is an expert in health inequities, social determinants of health, and health in all policies. And she has also had experience in workers' health. She is advisor, or was regional advisor on social determinants of health in PAHO, and she is a member of the Technical Commission on Social Determinants of Health of WHO. So thank you very much to all of you for accepting to be here. I didn't introduce myself, but I am Enrique Vega. I'm head of the Healthy Life Course unit at PAHO. First of all, to discuss 2 or 3 issues with us that will help us motivate the participation of all those who are here. I hope it becomes a more dynamic conversation, and we may visualize some things, what we know, and most of the ones that we do not know, and to have an idea of things that had been done or we have had positive or negative experiences with, so that they help us think a bit about how to achieve this result of achieving health for all in all ages. First of all, I wanted to say something about what effective access to health and health coverage means. Discussion in recent years has been destined to saying that it's not enough we have informal access to health services, that sometimes provide certain services which are very much structured, but they are rather far from the needs of people that respond to demands, to acute demands associated to acute diseases or disorders or complications of chronic diseases, but they do not have the structure or the continuity to guarantee the expected result, real result, in what people need for their health. So my question for everybody, it doesn't matter who answers first, is how can we advance, or how do your institutions think, or you, according to your experience, how do you think we can achieve more effectiveness in access and coverage towards universal health? Thinking, and that is one of the things I learned with Soledad and with a group of PHC directors, thinking that PHC is overloaded, that anything we say that has to be done and it's extra, and they will say, no, we have no room for that. How can we change that efficacy, that effectiveness of results in a context of where we are overloaded with services and work? Who wants to start? I will start because I'm the local. Like many other challenges that our public services face, we are now talking of health from BitLab, which is the innovation lab within the IDB. We believe in the value of innovators. We believe a lot in the value of innovation. And in fact, one of the phenomena, and we are now finishing a study together with Olon IQ, both of the public part and us in the bank, we have found that in the past 8 years there have appeared approximately 1,200 innovations in the region that is quite a significant figure, and somehow, in order to push forward with innovations, many of them have moved from what used to be electronic health record services, telemedicine, electronic prescription towards other types of solutions that have a lot more emphasis on issues of treatment, prevention, and diagnosis. So we believe that somehow the COVID pandemic allowed us to lower some of the barriers of innovation, because at that time of crisis, any state or public system was open to innovations. And I think that although this is still in an embryonic stage in the region, we strongly believe that these innovators will help us find, or will help us co-develop this type of solutions to see to this type of challenges that you were mentioning. But now I give the floor to the other colleagues so we can turn this into a conversation. Thank you for the invitation to be here on behalf of the Ministry of Health in Chile. Perhaps one of the things we had discussed with Enrique before was how do we go from innovation to investment? And that has been quite difficult in Chile because we have lots of innovations that we have somehow reached wide coverage, effective access to those products, whatever they are. But we have many, many good innovations that stay in the pilot phase. These are innovations that truly improve access, improve people's health. They are well received by the community, and yet we cannot turn them universal. In primary healthcare in Chile, we have per capita funding, as I had told you, or as Bernardo told you, which covers a family health plan, and yet 25% of funding has to do with programs to reinforce PHC, which are these vertical programs. Very good programs such as mental health programs, oral health, one that's called Show and Smile, so that is very nice, but they are not universal. If they are reinforcement plans, they are only for some territories and some specific populations. And that is a challenge that is quite complicated for us, and which is related to what we were discussing yesterday and before yesterday on how to make the Ministry of Economics to also understand that these are cost-effective innovations that will have impact.
And there I have a self-criticism. At health level, we haven't always been the best advocates for our interventions. We don't always have outcomes. We don't measure costs, impact. So it's hard to show finance the benefits of these interventions. Well, I believe that there are two key items here, three. First, that we want to modify health to do everything, so the pressure is overwhelming, and we need to try to simplify and make things easier for health professionals and provide them tools to improve their professional practice. It isn't so simple, but there are many opportunities. I think what you mentioned is very important. 1,200 innovations, and I think, and surely there are many more. There are many things occurring in the territories with health professionals, but a great challenge we face in our countries is to pass from implementation to scaling up. And I have a couple of examples, and we have worked on them. It's examples from the community in which I work, but it's clear there are many similar ones in other countries. Two. First, PHC and mental health. It's the other project implemented both in Brazil and Colombia, where the model is to train family health professionals with technological aid to do a better screening of mental health issues, depression, and alcohol abuse. And the intervention is quite simple, but it works well. We have a twinning of universities and mental health, he corrects himself, primary health care physicians. We use technology to screen each individual that consults PHC. This is an algorithm. There's a kiosk with a table, and people must respond some questions, 12, and this is a pre-screening. With that, people will go and see the physician who is trained to conduct a better screening, will be able to reach a diagnosis, and they use an app on their phone to access treatment. Some people need access to medicines, but few. There are many things that could be done with cognitive therapy and a mix of this mobile phone app and regular contact with your PHC physician. The data are very impressive, meaning that, well, this is an experience that has been published and funded by NIH in the US. But at the end of the experience, after 5 years, what we observed is that the level of detection of depression is higher, 0.1.5% of patients. In Colombia, we have a prevalence of depression that is very high, up to 12% of the population. So the detection level is of over 10% of patients in PHC. And the resolution level at the end of the year is very high. 90% of the persons don't have any clinical manifestations of depression after 1 year of treatment. And this doesn't require more resources. It is more effective. That's an example. Another is related with this work between the public and private sectors in Cali, Colombia, to decrease maternal mortality. That is a bit beyond PHC, but related. It's getting very specialized health professionals and low-level hospitals, whereby they create, with telehealth and telemedicine and other tools such as WhatsApp groups, training and 24/7 care to manage more extreme cases of maternal lethality. And this was implemented throughout the pandemic with extraordinary results, with incentives, exchange of information, training, allowing greater capability for solving these things. In Colombia, they passed from 70, 80 maternal deaths per year to 0 maternal mortality in these 2 years of the pandemic. They are very extraordinary outcomes, but they are a pilot trial. The major question is, how can we scale this up in very different countries with different capabilities. And what we're doing in the context of Colombia is to work with the World Bank and government to implement these scaling up implementation strategies with incentives for local players and central government to manage to have better results. That's what the Colombian government has called a shock plan to implement at scale. And we're learning. But what I wanted to stress is that these innovations may have a great impact. We need incentives and capability and to focus on outcomes with all the tools that may help professionals to achieve these results, but taking into account all the pressure, because the burnout level we have at hospital is extremely high. So what we cannot do is add vertical programs one by one. That would be against the work conditions, including innovation in a model making things easier for them that may help them to do the things they want to do and really have quality outcomes with a greater impact. Thank you for inviting me, Enrique. Continuing then with what has been said, not to repeat, I would emphasize that innovation processes sometimes are focused on technology in terms of the digital contribution and platforms that help. We also have an essential component that's a social innovation that has occurred with the innovation of institutions and practice. An important innovation in the context of the pandemic is that vis-a-vis weaknesses of the health system and the institutional government response, we have local responses from the community and local governments. And the first challenge I think we face is to listen to these innovations. So our discourse of the vertical practice should be bottom-up also regarding innovation. Transforming pilot studies and scaling up depends on the political will in terms of how we understand these innovations. So in that sense, innovation occurs par excellence in local ambits, in the territories and the communities. And in this framework, there's a central issue, and rescuing what we discussed before, that one of the major challenges is to have greater access and effective coverage in relation to the inequalities we have in the region. How do we understand the reasons for non-coverage and access? The access is diverse. According to diversity, there's even lack of access to the internet. Some things are not applicable there. In others, there are other capabilities at local level and assets in the territory. And we ought to be able to make the most of them with the processes of change. And PHC teams are over demanded, so we could do different things. So the discussion we've had here is ultimately this challenge about the model in general terms for PHC that we need in our current situation. What you said in the introduction, this diversity of age groups in the territory with different demands, and it isn't only mother and child, and doesn't only occur within the health facilities, that the care is in the communities, in the territories, that medical care is not enough. We should also include different manners of care, and this occurs in the territories in different areas. So the challenge for coverage and access, in my view, is what is a proposed model for care, including these new challenges and aiming there. Thank you. Well, this gives us a room to pass on to the next item, and I open the debate. You just stated it, this issue about diversity we must care for in primary care right now. This regards different age groups, but also this structural change in the manner of thinking and feeling of people in relation to the health, and this has been made clear by COVID regarding immunization and other processes at the time. So diversity is a major issue we must attend to, and we must pay attention to capabilities of our PHC systems to care and understand teenagers. That's a major challenge, or the needs of elderly people, or of specific groups that appear linked to age, but gender also, social and economic conditions, places where they live, and perhaps also our responses are very rigid. We want to have a traditional health system containing a larger health concept, contextualized at social level, more comprehensive, and we want to insert this to provide and organize services in the traditional health context that has over 100 years maybe. So while you were speaking, I was thinking that many of these changes mentioned here occurred with greater intensity after Alma Ata. After this declaration in 78, the region has had so many changes of all sorts that responding, well, maybe not to ideology and the Alma Ata philosophy, but to many of the proposals, structural proposals, well, that is not so updated now. And I would like to know what you think about this and what is your experience in that field. How do we overcome that process of caring for diversity in the health processes? Who starts?
Yes, this is something that really goes well together with the vertical programs. And the same happens when you talk about acute respiratory infections, oral health program, cardiovascular health, and the health professional. And it has to be culturally pertinent, with a gender approach, with human rights approach, and the poor health worker falls back, because how many courses does the person have to take to really be able to face this diversity of contents, of subjects, and even approaches? So perhaps one of the things that hurts us in Chile is really how difficult it is to train the human resources, health workers, and how they come from universities without all those competences. It has improved somehow, yes. Nowadays, for instance, physicians are taught how to communicate with patients, for instance, which is something that when I studied medicine never had. What do you mean communication? And nowadays the youngsters have that training, or nurses and technicians and physicians have some courses together, so they learn to work as a team, etc. So I think that we cannot keep adding issues. There comes a time we have to innovate on how we train our health workers. What do we do with those that are already trained in order to consider all that? We can add more and more issues. Quality of care, there are horizontal, vertical, and diagonal issues. And really, one of the things that we are really lacking, and I hope we have more advances, is the training of health workers, that they may come with all those approaches already considered so that they may be trained in more specific things. Just as I was saying yesterday, there's training similar to MHCAP and PAHO, or one of the problems of PHC is to have protected time for its own workers' training. They say, okay, when do we train? At what time? And then you have to stop training people in order to train. There is a knot there that is very difficult. And I hope we may have more innovation in that sense of being able to improve the way how we train our health workers. Yes, adding to what Maria Soledad said, in our analysis, we see very few solutions that truly face training of health personnel, physicians, nurses, and paramedics. So we think that surely in the coming years, this will be an area of opportunity. I will talk about technology again. It is the area where I work. And somehow it is difficult to think of universal experiences. Evermore, the issue of focus and in development with the person or the user of the system at the center of technology development is something that also happens in other industries, and it should also happen in the health sector. Not to be patient, but an active person in developing the solutions. And that is also something that is a trend. Instead of measuring our systems by the number of services provided, to measure according to results and experiences of users, and to acknowledge that diversity. We live in a very heterogeneous region regarding urban and rural populations. We have distant areas. We have a pending issue with many original peoples. We also have differences in socioeconomic levels. We have lots of people who spend, if I am right, 35% of the health expenditure in Latin America in 2018 was out of pocket. This expenditure, emergency expenditure, because the public systems did not respond. So acknowledging these diversities, not just ethnic or gender or age, but rather socioeconomic, I think we have a lot there to advance. And Jeremy, the challenge of scaling up, and we can leave it for the end, is also related to regulatory matters. Many solutions have that difficulty or have that challenge of scaling because regulation is still going behind innovation. Yes, I would like to add something from what Enrique says. It's a long discussion regarding horizontal and vertical equity. How do we respond as services, not just with equal services for everybody, but also according to the group's needs. And from planning, we generally do it from the program supply, what resources are available, not from demand. And that is so because resources are always limited, and how difficult it is to respond to certain groups and territories when faced with this diversity that is not only related to health groups and age groups, but cultural belonging, different territories and contexts. And the challenge there is how do we integrate services and care which fragments things, fragments our response. And that happens at the level of ministries regarding programs and departments, and also within the organizations. How do we achieve an inter-program outlook? So the challenge is to integrate, and second, how can we actually move towards planning that is coming from demand and acknowledges what the needs are at the territory by the teams in order to plan. And that is not what happens usually. You generally do it from program supply and the regulatory side. According, I think this requires diversity because it is the issue of the inegalities that we have in our countries, which are the most important in the world, and also the level of acceleration of innovation and its manifestation in the growth of these inequalities. We live in a world where 1%, top 1%, who lives in Sao Paulo, Santiago, Bogota, has access to levels of medical advances and with a genomic uh, revolution, personalized medicine that are extraordinary, but at the same time, we live in countries where peasants have no access to any health service, or in many countries, to any public service. We have deserts of public services, and that is a great challenge, particularly in a context where we have a judicialization that is ever growing of access to innovative health services. So we have an important risk of seeing, and it's not what we want to see, of seeing many more resources used for few people in the health services and a worsening of this diversity. I believe that the work that we have carried out in the World Bank for 4 years has a lot to do with how can we think of a very different trajectory, a trajectory which is that of healthy aging with a life cycle approach. And that is why PHC has a lot to contribute, but we also need multi-sectoral interventions. And the point is to say that what we need is to focus on cost-effective interventions that are really focused on life cycle prevention and the complementarity of investments that are multi-sectoral, especially with a focus on health taxes, tobacco, alcohol, sugar drinks, and countries have lots to do to intervene early on risk factors, but also to create the fiscal space needed in countries, and to intervene not just in the health environment, but in the educational and work environments, and to think of health as an investment in human capital with the reduction of inequalities and economic growth, improvement of productivity, and to close the gender gaps with better access of women to the labor market, and how to understand morbidity in the last years of life, and to improve the contribution of human capital and all people, not only to the economy but to society. I think this requires an important paradigm shift of how we see health and investment. But what seems obvious is that we have an important growth of non-communicable diseases, of disabilities, and we have a vision that is very short-sighted regarding investment in human capital in the first years of life, and that will not work in societies where inequality is very great, such as we have now. The good news is that the type of PhD that we have discussed may contribute to this agenda, but a PhD will not solve everything. We need a multisectoral action at governmental level, at societal level, also with a contribution of the private sector to decrease morbidity in the final years of life. That is key to avoid this scenario of somehow confiscating health expenditure by a very tiny portion of the population. I do not, well, I think everything that you have said is fundamental, and I believe that at the end of the day, complementarity of service delivery is very important. Many of the results depend on what you have said, including health in all policies, etc. But at the time of integrating services in PHC, and we were talking about that concept that it's a bit shocking for me, our health thought or our sanitary traditional thought with wider concepts of health.
PAHO has been defined in many manners and, well, not defined, but rather used in many ways. And thinking about what Anna just said, I would like to think that PHC may function as an open source platform. Well, it ought to be an open source platform where the multi-sectorial insertion capability would be more effective. In the health sector, we generally want the multi-sectorial relationships, but controlling them. We want to be the bosses. So they come to work with us, but we don't work with this open view where many of the interventions that burden the health human resources, preventing the generation of new manners of health human resources that are not described. It isn't a nurse or a physician, but maybe a manager, somebody responsible, well, the long-term caregivers, and so on, open to a more cooperative structure without necessarily requiring us controlling processes very closely. So the challenge of multi-sectorial integration, particularly in social services and so on, be still complex. The acknowledgement of provision in non-traditional environments, schools, workplaces, communities begins to occur, but it still finds hurdles. How then do you visualize that we could work in the future decades to manage more effective integration of social and health services? Chile has good examples that are currently occurring, but integration with the educational services to make for a more successful experience. Some have been born and died, others are renovated every now and then, but we need to have a framework to advance towards this sort of integration. Who would like to start? Thank you, Enrique. Well, I think that's a major issue, how to work in an integrated and coordinated manner at multisectorial level, intersectorial, transsectorial. Health has been present there. But I think there's a central issue thinking about regional processes, particularly in the ambits of social protection and at local government level in terms of development, because a technical component also includes a political component, and state monitoring regarding efficiency, synergy, non-duplication of tasks is one element, but the complexity of health issues and challenges in terms of inequality makes intersectoral work an urgent need. And another thing you stress is process sustainability. When we have many intersectoral tables and committees, well, as many as problems in a territory, but it fragments and not necessarily integrates. So at intersectoral level model, we need to have the political cycle, but health institutions, because the other sectors don't have to become health agencies, and intersectoriality isn't developed because we do the same health actions in the same way in a different place as compared to the health center. So how do we integrate the social and sanitary matter regarding actions and programs conducted? And I think that in that sense, we have many issues. One, regarding how other sectors, apart from the health sector, visualize us. And thus, when they see the Ministry of Health as a Ministry of Disease, the rationale when building joint work is limited. So we must train in this area, going beyond the sanitary sector in relation to joint work. We also have the different administrative levels that vary in the countries that are federal or centralized. But how is this intersectorial work expressed, particularly when we deepen inequality and inequality in health in particular? The intersectorial work is central because there we have the origin of inequalities, and we have a mandate to seek the intersectorial work that indeed aims to reduce inequalities and transform processes in practice. But we need to train and organize services, and what we mentioned on the first day. One of the issues limiting intersectorial work is the way how this is structured, because the follow-up and assessment processes for which there is a budget makes it hard to integrate resources among sectors and to assess. So there's a competition in terms of resources, so it's hard to integrate. On the other hand, and this was mentioned regarding the regulation, when there is great fragmentation at institutional level and of the public and private presence in outside the health system, for example, outsourcing social services, the government role at intersectoral level is quite weakened. So there are that sort of challenges we must sort of rescue. I will return to diversity of health systems. We are in a region where health systems are quite diverse also. And this leads me to think about an experience we currently have in Dominican Republic, a country where primary care doesn't manage to reach a whole population. And at present, we're deploying a first pilot plan where this primary care and diagnosis address to chronic conditions occurs at the pharmacy level or in other players that are not necessarily part of the traditional health system. I think then, well, I'm not coming from the health sector, so maybe that's why my view is a bit different. I think that that degree of opening to think that if the service is of quality comparable to what we want for people. We think that maybe the traditional provider could be complemented or supplemented, not replaced by other players, if we truly want to reach the population that is not cared for at present. So honestly, I think that public systems in particular and the decision makers regarding public policy and health matters must acknowledge their constraints and be open not only to multi-sectorality but to multiple players. So adding on to what a colleague just said, understand that surely if we want to reach this goal of universal care in the region, we ought to be open to have other players providing, and the role of the state would be to ensure the quality of that delivery. Okay. That is a fundamental question. I want to go back to some of the challenges we face in the health sector in the region mentioned yesterday. On the one hand, we have demographic and epidemiological very important changes with rapid population aging and a burden of diseases due to non-communicable diseases that is high, multi-morbidity, chronicity, creating very difficult conditions to adapt the sector on the one hand. On the other hand, we've also mentioned challenges related to climate change, particularly for this age population, and we've also discussed challenges of human mobility and migration. These are some of the important challenges we have to face. In turn, we must consider how the more resilient health services may adapt with this focus on PHC, with the challenge of adding an overburdened sector. So somehow, I'll give a couple of examples to help us to think a bit how we may shift our paradigm and advance with more preventative and predictive models. For example, if we think of this example of climate change and health, we know that there are many consequences and a very high vulnerability level in the region. And what we do, for example, in Colombia, we're working together with the government to integrate IT systems to have very more advanced surveillance systems. And this means we must integrate public health data, climate change data, and animal health. So we have this one health view to integrate data in order to have early warning and predictive models that are very precise and may tell us that for certain very vulnerable population in each block of the country, we know that this set of conditions we have has a much higher risk level in order to mobilize community workers and PHC for them to take action in a more focused manner. And I think this is really a key matter. We must invest on IT systems in these regions. These IT systems are very fragmented. They don't speak with each other, but there is a greater capacity now to solve this with predictive analysis, develop much more preventative services for smaller population groups, and this provides us a great opportunity to work in this way. In this sense, the work in the field we do every day with multidisciplinary PhD and social community workers going from one home to another to understand the risk factors with a vision including the social determinants of health is key. And this must have a certain investment level so as to be close to these communities, to understand their needs and act in a more preventative manner. And last, we need to acknowledge that there's much to be done, and we must invest on social systems, particularly care systems that are lacking in many of the countries. That is why we will have to make a great effort, because if we don't, the consequences will be that we won't be able to reduce inequalities. Unfortunately, we have this lack of caring systems for the aged people, and this has a great impact on the lack of development of formal work systems, and this leads us to the exclusion of a major part of women from the labor market, because they are the caregivers and they don't have the chance to contribute towards the growth, the inclusive growth of the economy, and this is reproduces inequalities from one generation to the other. And I think that this question is you made to us, Enrique, impacts on health, but particularly also on this possibility of developing much more inclusive societies.
Yes, I believe that what has been said is how we have been thinking of this issue of integration of care in Chile. It is an important issue. And I was thinking that we start humbly doing a paradigm shift, as Jeremy said, which finally the issue of CSEP and the strategy of people-centered integrated care. How do we see adults? Because CSEP is only for adults. Adults as a person with different multimorbidities, diabetes, obesity, smoking, etc. And that was a paradigm change. Then we say, okay, how about the life course approach in them? Well, not so strong. It's like, well, when they become adults, when this health condition has developed, okay, we have to include the life cycle approach. And there we are lagging behind, but going from vital cycle to life cycle, to life course, including the longitudinality of each person, etc. Well, now we have to integrate life course and health, multimorbidity, but also the person, because people are not just a kidney, they are a person, but a person who lives in the world and thus has interaction with all ministries, with all sectors. And in that sense, for instance, a clear example about how that person in Chile could live that situation, how somebody takes care of a severely dependent person. That person needs health care, of course, but they also need transport and a respite, some time to go out and breathe instead of looking after somebody else all day long, of a severely dependent person. They need reforming things at the house, perhaps receiving training. And how do we do that without taking the ball home, without wanting health to lead every time? In President Boric's government, one of the things we are working on and we are advancing is the national care system, and that was not led by health, but by social development ministry. And it was not just led by them, but we are also working in a high-level group where, as Gabriel said, when we have an intersectoral mental health table and one for cardiovascular health, and well, and they're all intersectoral, but we are fragmenting again. No, in this case, the national care system for everybody, for children, the elderly, for people who are dependent, and also with high-level people. We have a CAPI, a committee, an interministerial committee of high authorities with participation of the ministers, and then a lower committee with undersecretaries. Yes, undersecretaries. And we are working in order to generate a law that would allow us to have a policy of national care systems. And I think that brings hope, because we have the political will to establish this system. We are working in good coordination. The group includes housing, transport, public works, of course, education, health. But we are just one more in that. And I think that I am truly hopeful that that will work, that will advance, and that we may have a governmental response that responds better to people's needs. What Ariel was talking about, also having a supply or to consider care and health from the supply side, from demand and not from supply, I'm sorry, would be the tip of the cake. Because right now, in this group, we are just analyzing what is the supply government-wise, and then we shall have to say, well, what do people need? Because perhaps we are supplying things that people do not need, or we are missing things, or we have to change. So I think we are walking the right path. There is a good road ahead, and I believe it's quite virtuous that it is being led by social development instead of health. Well, thank you very much. I think what has been said here is fundamental. We have a few minutes to receive questions or comments, criticism, talk bad about the panel members, any variant. Good morning. I am Departmental Director of Health in a department in Uruguay called Paysandú. First of all, I wanted to congratulate you for this round table that has been so expressive and that started with something as important as what the moderator said, which is that we have achieved in a very short time to have this life expectancy, and that is the longest road always starts with the first step. That allowed us to reach that, but when you reach that stage in your life, you get new problems. We have that, but we have acquired new problems. So primary health care will now have a new chapter of providing primary care for those people. Panel members have been very important for me. Each one of them made very important contributions, and I would like to rescue some of the things that you have said. The fact that How do we innovate and improve? Yes, there are many things, and what I always say is that here the smartest, the strongest is the one who adapts to change. So the changes we have, such as climate change, mental health changes, which have brought forth by this new way of living with tremendous stress, with drugs which alter the lives of our youngsters and our population, generate a change to which we must adapt. To that change, you said, COVID-19 left us teachings, and we can have innovations with technology, but this technology, the population is not prepared to receive it, because first, in order to reach everywhere with technology, you need many tools and lots of money to have that possibility of telemedicine everywhere. So it's an innovation, but on which you have to work hard. You said we need training in technology and lots of investment in technology in order to develop that, which will help us a lot. But also, right now, the population is not prepared. It will be different in 30 years' time, when today's children who manage technology will be more prepared to understand all the plans and applications that we want to include in the health sector in order to take it to different sites. But we have to train people. So these are all important changes. Another important thing that you have mentioned in the health team, it is the physician is very important. About him, but he or she is very important because of his or her training. He has a vision of medicine that may apply all these techniques of primary health care. So that physician is not prepared either. You have said that schools of medicine have not taught us yet all that training in using human resources, such as social workers, nurses, etc. Everybody who are human resources associated to medicine, who are so fundamental to reach the population. That is another innovation that must be introduced into the School of Medicine. That training with an idea of primary health care, which is very important, so that I think that you have touched upon almost all subjects. You have shown and what can be done, and we have such a large continent that international agencies have to make an effort because they have very different countries, and that needs adaptation. Something very important is that the access in order to apply these primary health care systems is to say who will lead that team. This can only be achieved as teams. We know that, but who leads, who guides, and the access has to be the Ministry of Health. The Ministry of Health in this country, which has a good strategy of the pyramid, we are important providers because they send us the programs and we execute programs as departmental directors of health. We know the territory and we know who has the different technicians, and we try to integrate them because we do not have the human resources. The problem of PHC is that it grows and grows and needs more human resources all the time. So we have to point towards technology, towards physicians, teaching them with a different training so that they see what medicine is and that they value primary health care. And the other axis is that everything is done via the Ministry of Health. Thank you. Another comment? Good morning to everyone. I'm Dr. Manuel Rivero Avella, Director of Medical Care at the Ministry of Health in Cuba. I wanted to congratulate the panel. We have no criticisms. We have learned and listened to the experience of the different countries. We would like to start by saying that obviously, and we shall say it, primary health care, faced with the challenges of mankind now, has to be developed today. And the programs included in it, for instance, the mother and child program, which when we analyze indicators, development, quality of life, etc., without primary care, we cannot achieve expected results. But also aging. For instance, when Europe took 100 years to age, Cuba aged in 50. And the same in many of other countries in America with similar situations. Mental health policies towards adolescence, childhood, and all that has to do because our youngsters today are not the ones of yesterday. And all those policies are carried out in primary care, as Cuba on January 4th will have 40 years of the program. And we have had to rectify some aspects, but just to give some examples, which is what I wanted to show the importance of primary care. In 1985, no, in 84, when primary health care started, infant mortality was 12 in those years. And with the program, we reached 4. And now it is 7.2. And we regret that rate. And all that was possible because of primary health care. Another example has to do with vaccinations.
And remembering about COVID, not to re-experience it, but the experience, yes. All the work done with primary care, we managed to have thousands of vaccines in a week, in a short period, when we started the immunization program, because in each Cuban area we had the family nurse and physician program. If this is centralized in secondary care, if it had been, we wouldn't have managed it. And even in more developed countries in the rest of the world didn't manage to do what primary care did there. And last, everything regarding the budget. 48% of the Cuban budget is for public health, meaning there's this will 48 in all ministries. That is when nearly 50% of the total budget in the country, meaning that there's this political will in government. And this is an important figure. There's an important figure for PHC also. At present, training that has been mentioned today, well, we have managed to have over 95% of physicians graduating go directly to an office, but also specialize, that is. So they don't have long years doing social work, but going directly to specialization, because we don't want GPs, but more specialized physicians for some time. And health in Cuba in the 80s was all secondary care. Even when the program started, it wasn't believable. And that couldn't be done with campaigns or anything of the sort, but with the examples I've given demonstrating that primary care is truly sustainable and the basis for a health system wherever. Thank you. Yes, we're on time, so we don't have time for many more comments. So because we started late, I will hand the floor to the panelists so each shares their final thoughts. Starting with you, Uriel. in the Far West. Thank you. Thank you all. And maybe emphasize that from my ambit, it's important to approach health inequalities to be more effective and have more scope and coverage and access. And when we place a lens on cost effectiveness of actions, maybe we ought to use the same lens to know which interventions are effective at equality level, effective equality. That's a step we should take in the region. Returning to what I said at the start of my presentation, there are many innovators in the region that are thinking of solutions for the main issues in the region. And I think that it's worthwhile thinking on interventions that facilitate this co-development of new innovations with this vision. Well, I think that regulation is important to incentivize innovation, but it should be flexible enough and open to recognize or assimilate within the health systems this sort of innovations, because I think that the challenge in the region, well, demands that all players, the public sector, civil society, people in the territory, the academia, but also entrepreneurs and innovators be part of the solution. And last, stress the importance that with the advance of technology, it's important to have ethical data and privacy management, two very important matters that we shouldn't leave aside. So thank you for inviting me. I wanted to emphasize what you said. I think that's key. On the one hand, we have this rate of innovation advance that is very fast and will accelerate, and at the same time we have very complex and fragmented systems, and in many cases over-regulated. How will we manage this tension between opportunities and the need to innovate in an increasingly rapid manner with systems that are very rigid? On the one hand, we have an answer because there are many countries that have exception regimes for innovation, a sandbox, but in turn, that's not enough because we need to strike a balance between clear rules of the game of how the systems operate, but at the same time create more room for innovation with new sorts of solutions. This is very important for all of you that play this role of stewardship of health systems, working on the design of systems, because somehow a type of equilibrium we will need, and we're here to help you, of course, is in relation to how to create more learning capability regarding innovation and how to implement this sort of solutions at scale. This also means thinking about the people who work in the implementation of health services for the population and working with training and educational systems to include this in the initial learning, particularly in the clinical professions, this capacity to include innovation among their CV learning models, because the professional will change increasingly fast and they need time, but also capacity when they leave the medical schools, the social worker school, or psychology schools, or nursing school, to be capable of using this technology in a more agile manner. Okay. At local or national government level, I would like to highlight the role of international agencies in our work at local government level regarding health. And an example I have is what Ariel is doing with the health reform and the famous Axis 3 in the reform that is related with the social determinants. And in the end, tell you that for us as national governments, it's very important to work sort of in this good news or gospel sharing thing. What Ariel does with social determinants and others do with life course. It's important to have areas to think together and say, okay, what we're doing looked with this lens. What is it? Because what we do every day is generally solve emergency solutions of HIV, lack of vaccines, and we're every day trying to solve that sort of thing. So maybe for authorities, ministers and national directors also, it's important to have some time to think and integrate these approaches in our everyday work and asking us what is happening and extend their view regarding our own everyday work that is often so focused on very specific things such as specific topics or fires, quote unquote. I think that the role of international agencies is very important, and we ask them to continue doing that. Thank you, Soledad. Well, of course, what we've discussed is that systems, primary health care systems, resilience is very determined by understanding and responding to the population and health needs as a main goal, and that this care and view regarding their health needs is mostly determined by diversity and a dynamic transition that is very fast and is a challenge to us. So we must be able to adapt to those processes. So thank you all for allowing us to have you here with us and you for sharing this panel with me.
con el primer taller. La idea ahora es tener sesiones un poco más interactivas. No quiere decir que las anteriores no hayan sido muy interactivas. La idea de este taller es presentar las herramientas de cooperación.
We are presenting the tools of technical cooperation that are available from PAHO to strengthen this PHC approach to strengthen public health systems in the region. The introduction will be by Ernesto Váscolo, whom you've heard these past days, and we shall hear also a presentation by Sergio Minuet, a consultant in Ernesto's unit also, and we shall hear case presentations where these tools have been applied by our advisors in health systems and services in the country offices of Ecuador, Peru, Colombia, and for the Eastern Caribbean islands. So for that, I will ask Ernesto Váscolo, Sergio Minuet, our advisor in health systems and services in Peru, Hernán Rodríguez, our advisor in health systems and services in ECC, Andy Partatzing, our advisor in health systems and services in Colombia, Mónica Padilla, and our advisor in health systems and services in Ecuador, Javier Uribe. Ernesto, you have the floor. Thank you very much. How nice it is to have all the colleagues here. Sorry, I had forgotten to announce one of the persons. We have a space problem. Ernesto will be standing because we don't have chairs. We have comments from Brianna Rivas Morelo from WHO. You know her because she was, please come. Ernesto has been sitting a lot. They stole my chair. Thank you very much. Well, how nice it is to have the colleagues here in this workshop, and I will be limited to this introduction that more than about the panel, it has to do with guidelines of the unit's technical cooperation work that we wanted to stress. And here with our colleagues, we thought it was relevant to have an umbrella for this discussion. First of all, the primary health care unit and integrated health services provision unit, although it is very strong because it was rebaptized only a few months ago, I think it is important to stress three axes within it. One of them is or has to do with policies, with governance, with leadership, to strengthen leadership and stewardship by health authorities. That is an area that I find very important, which became even more important in recent years, not only as conceptual frameworks and developments and interpretation of processes, but also with tools, working tools that we shall see today. The second point has to do with financing, and I want to stress technical guidelines regarding technical support to support processes where funding is fundamental, but also regulatory matters in that funding component. And as I will also stress later on, the importance of grounding these instruments in subnational initiatives that somehow give follow-up to investment, innovation, and implementation. And the third component of our unit is the one we call services, where in a network approach, and particularly with that PHC approach, and with part of what we have been discussing these days with a territorial outlook, including not just the first level of care, but tertiary levels like hospitals also. This is the reason why the other two exist also. We have to consider them as facilitators of processes to strengthen the response capacity of health systems to population health needs. I want to stress two main levels of work. Not only our tools, our technical cooperation is trying to support reform processes at the national level in many cases, or at least in some cases in the region. Right now we have seen many examples along those lines, not only to strengthen reforms, of structural reforms, but I also want to point out the importance of technical cooperation at the subnational level. The development outlook, the need to develop capacities in governance and management and network strengthening at the territorial and subnational level. Finally, I would like to clarify one of the terms that has been repeated a lot during these past 2 days, which has to do with technical cooperation that is centered in countries. Not to lose sight of the fact that all this initiative that is regarding Alliance for PHC, which incorporates institutions at the regional, global level too, trying to strengthen coordination of their contributions. The central element has to do with country needs. Nobody can ignore the fact that there are agendas of regional and global agencies, but above all, the effort of putting countries and their needs at the center. Their needs centered on this primary healthcare agenda. But second main issue to me in discussion of what it means country-centered, it's not just to consider countries as receivers of needs, but basically to interpret them according to their own policy processes and their political processes, and thus not just look for our technical cooperation to strengthen stewardship by health authorities and critical actors, but to respect those processes. Our technical cooperation must not just interpret the context, but those processes that occur both at the national and subnational level and at the territories. That is my introduction. I will not sit due to obvious reasons, and we shall play the chair game. No, something will go wrong. But that is my introduction. Now, Sergio has the floor. Good morning. Thank you very much, Ernesto. Thank you all for being here in this workshop that has a competition, I'm sorry. And if you can please show my presentation. for a brief introduction. This is our program. We are like 20 minutes late. I hope we can adjust to win the prize that Juan Pablo has announced. There will be a first part that is a general review. Probably many of you who are working at countries and in PAHO know well enough, but it tries to frame the environment for this discussion. And I think the most important thing is in the middle, which are the presentations by my 5 colleagues regarding the use of certain tools in their countries. And finally, a debate that we shall try to have amongst participants regarding 3 fundamental aspects of any instrument or methodology that we want to use at the time of improving services and systems, which are their uses, limitations, and capacity to adapt. The objectives are 4. Ernesto has already discussed it, the importance of having useful resources for cooperation. Second, to present a catalog that never covers everything. There are always things missing. Third, to identify good practices. All practices will have a common element, which is the utility or the usefulness to produce analysis at the country level. And we have particularly selected those that have used different tools as complementary elements that are always interesting, and the final objective, which is to analyze our limitations. These are some of the opportunities for improvement that we may find in this transition towards the objective of universal access and coverage. Sometimes there are countries or subnational levels or territories that have clear problems of governance or funding or delivery, and the main problem may have to do with the first level of care or coordination amongst levels of care. But sometimes the problem is systemic, as yesterday we heard the professor from the George Washington University, in terms that it affects all of sectors. And there are reference frameworks that help, like a flashlight, to work in the dark, and they are well known by you. In the past 15 years, Pan American Health Organization has developed ample amount of frameworks in order to organize and improve the delivery of care.
But in that sense, and we've been working on that for at least 6 months, I wanted to highlight 2 matters. One has been broadly discussed. There was an excellent presentation yesterday about the country use in the case of Colombia with the essential functions of public health. But another that somehow guides us all, that is a framework that WHO established in Astana in 2018. That's an operational framework for PHC. And this has allowed us to frame this whole set of tools that you've used, universal health monitoring, FESP, PERC, everything regarding tools for improvement of integrated health service networks, and some more specific problems, waiting list management, avoidable admissions, or operational prolongation of PHC. All these tools have been developed by HCS and PAHO and enable a situation analysis that could be at national or subnational level or local level, as Ernesto said. Others are being developed. For example, monitoring using the framework is a very useful tool mentioned yesterday by different speakers, and DEEP that will be now introduced by Diana. This is a small chart that tries to represent, well, we can't fit all the words, but in the upper part we have countries in the region, and at the side different tools And there you see the different intensity in use, very close to different situations of the health reform. Some countries have a more stable health system, although none is truly stable, and others are undergoing a reform. Of course, there are some with more reform processes or where it's more intense, and those have more need to use this sort of resources. In the geographical distribution, you see the main tools we have in the different territories, with a predominance of use of some in countries such as Ecuador, Colombia, of course, Peru, Costa Rica, El Salvador. And what are they useful for? They are an important element to respond to the needs to progress towards universal coverage and access, meaning that to progress, we need to use these tools. No, not necessarily. They just serve as tools for expert professionals that know which is a screwdriver or hammer that is more appropriate for the case, and in the health case, the appropriate knife or whatever to solve a problem. They are all available. We believe they are useful. Not all have, and I'll wrap up here, the same usefulness. For example, here you have in the chat those particularly useful for issues of governance and funding, monitoring of universal health, and operational framework for PHC. In the case of management issues per risk or assessment of essential conditions that are quite useful. And in the case of healthcare, apart from the systemic comprehensive tools that encompass a whole model, such as risk, then we have others that are more specific. All or some, in particular, encompass a key element in governance, such as accountability regarding with the outcome analysis, be it process or final health outcomes. And regarding the general framework, I mentioned at first, for the PHC operational framework, many of them are useful to conduct an analysis destined to produce change, and this, of course, at country and subnational or local level. Thank you. I now hand the floor to our first presentation. I think it's the HCS advisor in Ecuador, Javier Uribe. The floor is yours. Thank you, Sergio. Pleasure to be here with you all at this event. It's lovely for us to be able to share the develops achieved in Ecuador with a fundamental element that's full participation of the health ministry team, not only there, but also including the Vice Ministry of Governance. That's been a fundamental pillar I wish to highlight because it has contributed to the project's success, but also to strengthen the stewardship of the Ministry of Health with the tools used. Another fundamental item is the role played by the community from the start of this cooperation, posing their active participation in all the calls we've made. The goal for this cooperation was to strengthen two integrated health service networks, one in a context of the hills. Ecuador has 3 territorial levels, the hills, the coast, and the Amazon. So we selected a mountainous area and a one in the coast. This included the strengthening of human talent with training, with a integrated network diagnosis, and then we began to see innovative change. I have experience in different countries, and we made a network diagnosis. But in the case of Necoda, we took a step forward, generating an improvement plan with the directorates in each team. And additionally, as Sergio said, we see the potential of using tools. The network is a general contribution. The assessment of the essential conditions takes institutional pictures of each of the players in the network, and as you may understand, there are stronger and weaker players, and this generates an improvement plan to contribute so that each player may improve. Of course, the diagnosis of access to health services was made, and together with the ministry, we defined that the access workshop had 5 pillars that the ministry considered a priority: mother and child health, immunizations, cervical cancer, mental health, and management and prevention of cardiovascular conditions. In a cooperation program, called Hearts, and community participation has been an element that seeks to generate capacity building public health, but governance also, without leaving people aside. This is most important. They must participate and help us to improve changes that the services demand. As I said before starting, we work intensely together with the directorate so that they take a position vis-à-vis the subject with online meetings. We did capacity building in the Ministry of Health with tutors to manage the online platform of the ministry, and after that we trained 75 officials in both networks in the online platform with a program for integrated health service networks. The diagnosis, as I said, was made for both networks with the PAHO methodology. We had an improvement plan that started to operate in July, and at 6 months will be assessed. We assess essential conditions for 2 first level of care institutions, the Yaruki network and the reference hospital, and 2 institutions in Mount Sinai network with a specificity I hadn't mentioned because it isn't the same for both. In the case of the Pascuales Monte Sinai hospitals, we included it also in the strengthening of the administrative financial network with the PERC program, but that isn't part. That's why I didn't mention it, because the Yaruki hospital that is of less complexity isn't part of this training, and what we were seeking was homologation of both networks. As I stated, after assessing the essential conditions, we strengthened the ministry with technical capacity building to generate the use of the tool in the future at national level. And last, we had a workshop with a diagnosis of hurdles to access for the 5 programs mentioned. In the context of barriers to access, together with the Ministry of Health and PAHO, in each of these programs, we also set a roadmap to strengthen capacity, technical cooperation. This will be the priority access for 2024, together with social participation in health. What are the challenges for 2024? Follow-up of the improvement plans, and in the networks and institutions, operational interventions to make each of these 5 programs solve problems of access identified together with the network technicians and health service users. Of course, we must exchange successful experiences among networks, and for us this is very important because we will visualize opportunities for cooperation together with Colombia and Peru, the Caribbean, in order to socialize these achievements. And we also have, as I said, in this view to strengthen the ministry, that each of these 5 program axes be strengthened with a presence in the territory solving these issues. Well, this was sent to us. The context of the Ecuador reality is that these 2 networks were extremely weak, and in Mount Sinai and Pascuales, there was a lot of violence. There are very critical conditions to access some of the units due to violence. So the mental health issues with the community and community is a priority for 2024. In the case of the main problems, we have a disarticulation of network work. The conditions, essential conditions were assessed, issues of access, and needs to strengthen competences of the health staff at central and territorial level. The ambit of action is national, subnational, and municipal. Tools used have been seen. It's important to have participation. As I said, it's always a real priority to work with the community, and also autonomous, decentralized governments. And of course, I couldn't attribute the success of this collaboration to myself. This has been a joint work together with the representations teams and colleagues from the Ministry of Health. The results have been already detailed, and to conclude, we are pleased to say that at present the networks have an opportunity for growth and development that will continue to accompany the main issue, that is passing, as stated yesterday, passing on from the technical aspects in the territory to have the users benefit, has been reached in articulation with 5 technical programmatic axes. And indeed, another element I wish to highlight is that both ministries are involved with this action. So this creates a very good governance situation, because in both there is a focal point with who we work and articulate all activities. So this allows us to formulate and highlight this successful condition that is because of that. And another reason, is, of course, is our work between the Ministry of Health at national level together with networks in the territory, and constant accompaniment to both management teams. And once again, I highlight the importance from the start with the communities. We all face challenges, of course, and that is to be able to socialize this with the different players. We wanted to do this in November, but because there was a change in administration, we'll have it in February next year. Strengthen social participation in health. This committee is very proactive and active to strengthen health provision, follow-up of improvement plans, and, as stated, strengthening and access of health delivery. Of course, this shows the support we've received in all activities from the Ministry of Health, and thank you all for your attention. We hope this is of interest. We are open if anybody wants any more information from our experience.
And I wanted to stress, as Mandela says, everything seems impossible until done. This process leaves us lessons learned of working in groups and in an articulated fashion, because we started in April and we achieved a lot. So this has shown that one thing is being able to do things, and we are pleased with the results obtained, and we are sure that with this alliance of primary care, with the elements that the alliance can provide, this initiative of integrated health services network in Ecuador will expand to other networks. This has already been said by the Vice Chair of Integrated or Comprehensive Care to the Director of Health Services and Systems. Our goal for next year to expand this experience to other networks. Thank you very much, Javier. Right now, Dr. Hernan Rodriguez, HSS advisor in Peru, will tell us his experience in the use of these tools. Thank you, Sergio. Good morning to all of you. My greetings to Ernesto, Juan Pablo, also to the colleagues of HSS who are present here, of course, to the audience in general. My presentation is divided into three components. One is some general data about the country, then advances made in Peru in implementing integrated networks based on the PHC approach, and some levels of the first level of care and the tools that we have implemented at PAHO, but not only PAHO, but also WHO's tools in other technical areas. So starting with some data of interest, there you see it. I just want to stress some of them. Peru is a country with cultural wealth, historical wealth. It has over 47 original indigenous languages. That's a population over 34 million people, but with a coverage of insurance of almost 99, here you see, 99.10%, and an out-of-pocket expenditure that remains high. It has gone down. 3 or 4 years ago, it was around 38–40%. Public expenditure, the 3.2 of the GDP, there's still an important gap to reach the regional goal. There you see the Gini index, the economic growth. You see some indicators of health systems, physicians per 10,000 inhabitants, nurses. There's also marked evidence vis-a-vis the average in the region. The most clear example, nurses, it is expected to be 70 per 10,000, and there you see the differences, and these are national averages. So the differences grow when you analyze by region. In some, they are more concentrated because professional population is concentrated in the large cities. This slide, I want to show it because we worked with some products in the first phase of essential functions. And there you see that configuration. The health system in Peru, just like others in the region of the Americas, is a system that is fragmented, segmented. There you see each entity, their social security, health, including the army, the police, the prisons, the private sector. But an important thing is that regions in Peru, all actions are decentralized. Peru has 25 regions, and you also see that in the case of the Ministry of Health, there is a series of entities that are adscribed and deconcentrated, but you also see the National Institute of Health, a comprehensive health insurance with a coverage of over 65% of the population, a fund, which is the FISAL, a solidarity fund in health, intangible fund, and other entities. But I just wanted to show you the configuration. The other thing is that there is a normative framework there in the bottom. You see Law 3885 of 2018, which establishes the conformation and functioning of integrated networks based on the PHC strategy, and a resolution from 2 years ago establishing an implementation plan for these networks. There are the 4 dimensions according to the PAHO model: delivery, governance, funding, and management. They have added 2 other attributes to this PAHO structure. And on the right-hand side, you see that we have just produced a document called Plan to Strengthen the First Level of Healthcare 2024-2027. It's a policy of the President and the Minister of Health, who want to advance in rehabilitating 1,000 locations. It's not just a matter of building. Some were new in a time lapse of approximately 4 to 5 years, because, as you see here, regarding the configuration of health establishment, the first level goes from 1 to 4, with more resolution and resolutivity in levels 3 and 4. But I have marked there in red and blue that levels 1 and 2 are right now almost 80% of health establishments. Only 20% belong to levels 3 and 4, and that's where there's more resolutivity, more personnel, more beds, possibility to provide care. And there is a recent diagnosis by the ministry identifying that 94% of establishments of the first level of care in Peru have problems with infrastructure and also with equipment and with human resources, important gaps in several regions. There are the other configurations. Now, I will go into the different tools succinctly. I understand that time is limited. What is the essential public health functions? We are now in phase 3, and I also wish to mention the support and accompaniment of the headquarters, not only for this tool, but for many others that we have implemented. Without its assistance and accompaniment, it wouldn't be possible. And recently, we have just measured the 11 functions, institutional capacities, and 236 gaps were identified. Next week, we shall have a meeting with both my ministries in order to prioritize out of those 236, which would be the 20 or 25 priority ones, in order to write an action plan or a roadmap, at least with 5 years' time. I think this was very important work. Something else is the assessment of essential conditions. We have experienced that in some integrated networks. I think this was more a pilot study. We have to fine-tune some things in Peru, particularly the creation of a central and regional team to advance in the implementation of this tool that really has many advantages. The other thing I also wish to mention is that we have carried out several studies related to access barriers. We are now about to start a 4th study. We started one in Condorcanqui in the Amazon region with a young and adolescent population about access to mental health services. We carried out another step in Chachapoyas, Amazon, and Raimondo Ucayali in order to know and identify barriers to access and facilitating factors at the first level of care in adolescent women. And we also carried out a study with the support of headquarters and academia, a study considering the most recent reforms since 2015 of the health system. A triangulation was made with systematic review, quantitative analysis, and also qualitative studies. It is truly a very important study following the Tallahassee model, and we are now going to carry out a study in the Tacna border, and we have also included Puno, particularly for migrants. So we have a good number of studies. Next year, we want to organize an event in order to socialize all these results. The other thing is that we have also used the tools for assessing networks. We did that in integrated TRS in Villa Salvador, Chulcampa, and Ucayali. I just mentioned them, but the difference is that one has urban population, the other one is urban and rural, and the other one has dispersed population. And measurement was made comparing a baseline of 2 years ago, and we found that there was an increase, an advance of these networks, but they are not significant. The percentage does not surpass 44%, and the greatest weaknesses are around governance and also social participation and financing. The other thing is that we used a WHO tool, I'm sure several of you know it, which is the Prevention and Control of Infections Evaluation Framework. We have implemented it in over 12 regions in the country, and that has contributed to the creation of action plans for hospitals and establishments to carry them out in the short, medium, and long term. We also had a visit from the headquarters and from two regulatory national authorities from Argentina, ANMAT and ANVISA, for an assisted self-evaluation to the Peruvian drug agency or medicines agency with the Global marking tool, which has 9 components, and evaluation was focused on sub-indicators B, level of maturity 1 and 2. The idea is that Peru in 6 months' time will advance to a level of maturity 3 in order to take its position in the region. And finally, you don't see it, we also worked in the validation of indicators of pharmaceutical services based on PHC.
This is a work done at headquarters level, and then we had a pilot of a pilot in 60 facilities of pharmacies, basic, intermediate, and advanced. And this has contributed to have many of the indicators be adjusted and validated. And last, the management of public financing tool. A long year ago, we created a team to work on this tool with the changes experienced in the country. And I want to mention, at the beginning of the pandemic, we had, I think he said 12 ministers of health, and this tool remained standby, but now we're committed to advance in its use by 2024. Last, final considerations. Whatever the constraints you may find in any country, in Peru, I think we have significant progress made. We truly prioritized according to the agenda developed together with the Ministry of Health. We haven't only concentrated cooperation with the ministry, but also with the different regions. We've worked in 12 regions in the country in many projects. As for networks, we've contributed also to develop a governance document and in the nominalization of the population to work with the integrated networks. I think we had a great window of opportunity next week to prioritize in the country these gaps of the 11 functions to prepare a roadmap. And we're quite sure that next year we'll have a capacity building of the regulatory national authority to progress to that maturity level. And two final items. During the past 4 years, we have created a committee of primary health care practices with 130 experiences. And last week, we handed the awards of the best experiences. And I think it's a good opportunity to expand and socialize it together with the different countries, because the results have been extremely valuable. And of course, we want to maintain and increase the cooperation agenda next year. We have this tool, public finances tool. We want to work with PERC and avoidable admissions. We want to continue with these studies. And I open a parenthesis. We're completing a study in the country, estimate public expenditure in the first level of care, together with a high cost and rare and orphan disease study. So we have many opportunities, and I think we're advancing in the cooperation agenda. So I'm open to any questions and sharing what we've been doing in Peru. Thank you. Thank you, Hernan. Next, Monica Padilla, HCSC advisor in Colombia, will tell us of the advances reached in the program and country. Thank you. Could you please share my presentations? I thank you for allowing me to participate. While preparing the presentation, we wanted to work a bit like a workshop on how to share from this giant agenda and select. Now, I would like to tell you our starting point. So I'd like to take a position at organization level, because when we generate the use of tools, you must be standing somewhere. So I think it's important to have a position regarding cooperation, a health vision, and technical and political agreements that are great support. We have these agreements that truly define a technical vision of how we want to understand health in the region. And this is important because it's a sort of additional backup regarding the mandate. And then we want to have an analysis according to each context. You mentioned it very strongly yesterday. What does the context mean? How to reach the field of health. This includes many forces, and there are some agreements that are better, others that are worse, but we want to gather forces and how the organization and other players may contribute to what we want. Players and their dynamics, and then the instruments and methods to organize and approach a complex situation. Our main goal is a right to health, and that guides us. And I think that countries have developed, and something that we thought in Colombia, we have comings and goings, but it's a space where the right to health involves some elements that are not always easy to achieve, but that's our mandate and our goal for 2030. Another thing is focusing on PHC, the reason for this meeting, guiding us powerfully and validated so many times after 78. And here, something shared by Ernesto and the Washington team and Natalia, that is the importance of having frameworks to organize all this. I took this from another meeting. Why should we define a framework? The instrument is a manner of establishing contact among players, and PAHO has this possibility of mediating to plan and define functions and responsibilities, reach consensus, have a plan based on a specific vision, setting goals and objectives and assessing what we do. So I'll tell you what we did in our work team in Colombia, together with the Ministry of Health and others. I mentioned different elements guiding us. There are more, but the agenda is, as Hernan said, very demanding. Here we have some of the elements. How do I read the health situation and the reference of the epidemiological profile with an equity approach? Social determinants of health, the context for development, the players involved, essential public health functions, how I strengthen government capacities, the performance of the health system, that is a framework to accompany the transition process in Colombia, how the system evolves in time, and we can demonstrate optimal functioning elements, model of care based on PHC, and just a few. This is a study where Ernesto, I see everything we discussed in this meeting with technical areas and how they impact on the work. This was with the social determinants of health team, and it's as a function of equality. So we have this map for intervention with a manner of approach defining integration among health indicators and equality issues. So it's one of the tools we can use to define our actions, making things easier for the people on the territory, because it integrates elements here, the social determinants of health. And the question is, what are the players that ought to work with us on this subject? What players we would work with to drive this forward? Now, essential public health functions. And here I pick up essential functions of the health of the public, because it isn't screening activities. That's political concept of public health involving this vision that might be different from the one considering basic services. We've worked on this proposal and defined all these essential functions we will consider, and there is a social player developing the function there. Sometimes it's fragmented. For example, Ministry of Health and Social Protection, entities that are close, others that works on drugs, technology. So the work there is integration, how to be consistent at government level, and that is one of our major difficulties. So here we applied the methodology. Dr. Martinez shared this rich process we conducted yesterday. It was really a huge workshop inviting all the departments in the country to discuss functions and capacities at government level. We had the map. The goal is to have a dialogue with the people to begin to implement government capabilities. This is one of the frameworks. And now I'll see the second. Assessment of performance of health systems. This in the proposal to support, to think the transition of the reform. So we are proposing things to the ministry. Could this be okay? We had a workshop, and there the technical teams from the ministry and the academia and others had a dialogue about the timeline. Who, where, when, how. This should be an instrument allowing the definition of the short-term work, because we don't have time to intervene. This is another tool to help us to manage the process. And then integrated networks. We have a whole discussion right now about how to organize the discussion of networks. That is an important demand, and in this sense, a recent workshop we held, and here you see the pictures, to have a conversation with the dialogue. So we have this in theory, but how then? And that's why I like the implementation group. How in practice? With who? Who are the players that ought to organize the networks in the territory, and it's a local responsibility to have it become a reality, a dialogue with the territory. People mentioned social participation. Here we have this first exercise calling best practices, Brazil lesson to obtain a change in the rationale of appreciating knowledge. Sometimes it's knowledge and best practices that seem to be in the center, but it's a territory that has a real knowledge of what ought to be done. So here we have the first awards and a call to build together solutions. So here we could advance with more elements, but when we were considering the workshop, the question is how to approach specific programs from cooperation and with our counterparts. I think it's basically building in what is occurring in reality, where we have the forces, and using instruments helps us to organize. When we enter with the instruments, we may run the risk of staying in the soft. The networks are increasingly more ambitious and energetic, with a capacity to share responsibilities. Functions we want to grant are only achieved when we begin to work. That's basically then the standpoint of I wanted to share with you. Thank you, Monica, and also for the effort to synthesize. And next, Dr. Bardacci will present the experience in the Eastern Caribbean countries. The floor is yours.
Good morning. I apologize, but I will speak in English.
Adelante. Presentation, please. So, I like what Monica said about positionality, and I think positionality is an important thing when we're talking about a concept, when we're talking about technical cooperation and how we orient ourselves to technical cooperation. So I'm going to take that perspective. As much as the other presenters took a country-focused approach, I have to take a little broader and take you first to what is the context of the ECC. So here we have that little box, that little blue box, those 10 countries of the Eastern Caribbean. Now, within that, you have very diverse contexts, country-focused contexts within the sub-regional context of the Eastern Caribbean countries. They're all SIDS, so with that comes their vulnerabilities in terms of limited resources, vulnerabilities to climate change, vulnerable economies in general. Variable population sizes, so it really influences how we approach, how we craft technical cooperation, how we use the tools that are available to us and tailor them to the country is absolutely necessary. So we have some of our representatives from Montserrat, for example, with a population of just over 4,000 persons. We have another, Montserrat is a UK overseas territory, but it's still within the spectrum of countries that we provide support. And then we have much larger countries in terms of population size, not geography, population size, like St. Lucia with just over 180,000, about 180,000 persons. But coupled with that are diversities in their GDPs, if you look at that as some sort of indicator for their economies. You have the British Virgin Islands with USD 48,000 per capita, and then you have Dominica, 7,000 per capita. Really, really diverse. And then pulling all of that together is their history, their developmental history, their evolution as member states, as independents, as territories from that UK colonial influence. And why I highlight that as an important contextual consideration is because how their systems, how it's organized, their governance, their ministries, is very much aligned or influenced by that UK approach. So, and the last part about the context is that You know, we use the word reform, and we use health systems reform, and use the word health systems transformation. The language in the region, or among the countries, is that of health systems transformation, and they're transforming their systems. I think maybe perhaps it's a little bit more politically neutral from a reform perspective as opposed to a transformation perspective. But it is within that frame of ongoing transformation that has, in most of them, have been declared at the political level that the technical support, technical cooperation is provided. Now down below is the emblems of two regional political conglomerations that exist within. So you don't have just independent states. In the case of the 6 ECC and Barbados, Barbados is an independent country. The other countries from Grenada up to St. Kitts and Nevis come within this umbrella of the Organization of Eastern Caribbean States, OECS. And so they have their own currency as opposed to Barbados. And so the influences are different. They come together in different ways. They agree in different things. For example, procurement of medicines with a pool procurement system. So there are these contextual or socio-political dimensions that are important, that influence technical cooperation. I'm going to present on two tools, reflect really, again, from the positionality of a region, using country cases to highlight some of the challenges, some of the objectives that Sergio charged us with. And the first tool is that of the assessment of the essential public health functions. We have three of the countries that we have this exercise, that we've performed them in this year. 2 of them we've almost completed, and 1 will extend into next year. What we were faced with is, and I draw your attention to the purple boxes. Many of you that are familiar with the process, the implementation manual for how you go about implementing essential public health functions, are familiar with the phase-based approach. We had to take a little step back and try to create that internal frame within the team that is working on the assessment, to be sure that what is it we're trying to achieve, how we're going to try to pull this together with the countries, how we're going to engage the countries, and then sharing that also with the countries, that external frame. So for us, those step 1 and step 2 were really important before we begun the process of steps 4 and 5, 3, 4, and 5, which really are more the phases of the 1, 2, and 3. And so we came up with the Essential Public Health Functions EPHF CAMBEC customized assessment methods for Barbados and the East. It didn't change the tools, but it allowed for framing it or the assimilation of that within the context. And I'll show some of the pictures when we come to the challenges that we face with the tools and the successes. And within there, the other element that we had to innovation, in a sense, for the region was to come up with one mechanism within the countries that would lead, so that it is really country-owned. And that's one of the things we try to promote. PAHO supported, country-led, country-owned. So we created the EPHF ACT, the Assessment Coordinating Team, with the hope and the vision that the acronym ACT will spur on action at the country level. So this is how we had to interpret the EPHF operational traditional approach to the ECC context. Now, when we came to applying that, if we thought that was standard, that was tailored enough, when the 3 countries that we applied it with, we had to do further tailoring. Because you have small teams at the ministries. Those large pictures that Monica showed with the large teams with the phases, not possible. If you were to have that, then there will be no other work that will be going on in the ministry for the days that you'll be doing these workshops. So you have small teams, and perhaps if we do get to plenary, we can have some of the, share the reflections from St. Lucia and Antigua. CMOs are both here. But small teams, but not just small teams where individual members are responsible for multiple portfolios. So when you came to now looking at how do we separate those subject matter experts for each of the different functions, the approach that we went into with this very, structured, we're going to deal with group 1 and EPH 1 and 2 and this particular session, we had to, in the moment, adjust based on who we had in the room and which functions and which skill sets were required, which capacities, institutional memory and experience we wanted to pull through. So that really is a challenge for the region, for the region as a whole. SID's context gives them that, that limited human resources to manage. But they're no less complex, that is one of the things that they still have the spectrum of complexities, spectrum of issues to address as larger countries. With the small teams and multiple roles with each team member, it becomes a very time-consuming, time-intensive exercise. But it was a challenge for us to overcome because the focus was on what is the goal, what is the value that is going to be added, and that's where the achievements, that natural progression to focusing on the contribution, the outputs from the assessment process as inputs to strategic planning, as inputs to their work planning for the coming years. And that is a natural part of the cascade, from the exercise to generate these outputs. But for us, and being from the region, it was the secondary gains from the process, a secondary achievement. And I think this is where the heart of technical cooperation sits. Not just the technical expertise that we share, but the support to pull together, to allow for that inter-country sharing and exchange, intra-country, sharing and exchange. Because it was the venue for persons who worked in the different functions, who in the different units, to come together and share, this is what is happening here, this is what I'm doing. And it allowed space for us now to advance that PHC, that approach, because while we were focused on doing the assessment, the bigger picture was the assessment that fits within this PHC approach, that fits within the vision for the country. And so we had to, there were these many side conversations when we were doing the gaps, the discussion of the objectives and the strategies to address the objectives as part of decision tree. There were times where we had to have little side conversations, as the CMO, Antigua is smiling, side conversations on the link with this discussion, this objective and this strategy, to the PHC approach, to the components within, and help that orientation or that sort of calibration on with the perspective. So that was a really important gain, I think, with the tool, that it isn't what the tool sets out to do, but within the region, it is an invaluable resource. And so that's why the title slide is high value and high applicability. The value extends beyond just an assessment of essential public health functions. From the position of the organization as a concluding point for this area of technical cooperation, I want to say that we are differently poised to provide support with assessing the EPHF in other countries, not better poised, because I think when you go into the individual countries, what you thought you were better poised, and the reality is you have to adjust again. So we're differently poised because we are more reflexive, I think, in the assessment of the essential public health functions with the ECC. So let me shift now focus to the health financing as another area of technical cooperation. It's less tools focused because you have, coming back to that variability, that variation in the context within the region, not just the population size and not just the GDP, but even if you look at the health service coverage index and you look at healthcare worker density, and you find that the issues around, the discussion around financing in the ECC context is equally variable. Countries are at different stages. Some of them are at the point of moving towards implementing national health insurance. Some are there at the stage of understanding or looking at how do you explore, how do you strengthen financing. And we get those requests, and these charts are just to share some of to show that variability, in the percentage of GDP on health expenditure, etc. But the same small teams and small roles creates a sort of fragmentation in the discussion around financing. It creates fragmentation, not just fragmentation from a service delivery perspective, but what are the different perspectives that they apply? So for example, you find that the Ministry of Finance is the one that sort of is the major player. And you have the budgeting, you have the sort of forecasting, the design coming from the Ministry of Health. But there is that gap, and some of the other countries have spoken to it, that gap between advocating, exciting the Ministry of Finance for the investment in health. There is also the focus on fees. There's a very history around collection of fees for services. So the cooperation in the area of health financing was necessary for us to be much more variable. We had to use opportunities to shift that focus, to create some perspective transformations on health protection, the language around health protection, the language around not fees per se, but or national health insurance per se, but financing health. And what does health mean for you, and what does financing that mean for you, to create space for the discussion on the essential package of essential services, looking at that first level of care, and we're doing that with some of the countries. So it really is, and then even at on a regional stage, we've brought together countries to discuss financing from the perspective of health taxes and in the fight against NCDs. So the technical cooperation in the area of health financing really is a different animal, so to speak, because of the nature of the context and the high variability. But it is an area that has high political priority. It is one that the heads and the members, the political leaders speak a lot of. So there is space there for advancing the tools now to really strengthen health financing with a view towards universal health. I think that is, yes. Thank you very, very much.
Thank you so much, Andy. Y la última, pero no la menos importante de las presentaciones, es la de...
Last but not least, our colleague from WHO, Technical Officer in Integrated Health Services, Liliana Rivas Morillo. You heard her yesterday at the very interesting table we had on monitoring and evaluation, and she will tell us about an experience that has not yet been used here, particularly in the region, but that I think has great possibilities in its leap. She'll tell us about it. Good morning. Thank you. It's a pleasure for me to share this new tool. As Sergio said, this is a different presentation because the tool hasn't yet been implemented. We are at a point where we need to validate, implement, and complete it based on experience and learning from its application. It's a participation, evaluation, and local planning tool. That's LEAP. I will speak on behalf of Auditorio, who unfortunately couldn't attend. To start, this is in English because it comes from the regional WHO East Mediterranean area, but it captures this change in paradigm we're discussing towards integration of health services, meaning a change from services focused on disease to an approach focused on people's needs. Acute services and individuals, but rather to more continuous population-centered services, from fragmented to integrated health networks and family health teams, from consideration of the volume of services towards not only taking into account the quality, but that services be in the appropriate levels in the system. And last, from reactive systems to proactive and prepared systems for future emergencies. So, in this context, we elaborated this new tool called LEAP, based on 2 WHO frameworks. First, a framework for a people-centered integrated health system, and the second one, we've heard of the operational framework for PHC. If you see the different elements shared, the only difference is that in the framework they are basically focused on integrated people-centered services, and in the second they are focused more broadly on PHC strategies, but all the elements are related with integrated health services that are based on the first. So, what is the local planning, evaluation, and participation tool? LEAP. It supports local health authorities to plan health delivery reforms based on PHC, and helps to translate the commitment with PHC-based systems towards health for all via integrated and people-centered health services involving people and the communities in the planning and intersectorial action. LEAP includes 5 objectives. First, supporting effective participation of all stakeholders in the health system, strengthening, guiding the analysis of health delivery with an emphasis in reorienting PHC care models, encouraging priority setting and consensus creation on common diagnosis and opportunities for improvement, for generating a process to select interventions approaching problems identified by consensus, and last, assessing processes and outcomes by monitoring, assessment, and learning. The tool is addressed to the subnational ambit health authorities leading health planning and PHC reforms, including the management teams and district officials and regional health coordinators and providers in the facilities. The tool has been developed to support the planning cycle that starts right there, where we have the circle asking, where are we now? Identifying needs and key problems. And we go to the second stage, wondering where we wish to reach and what is the vision, where the priorities and goals are set. And the third wonders, how can we reach that situation, identifying necessary interventions and resources to implement them. And last, how can we tell when we have reached the point? And this is focused on monitoring and evaluation, learning, and then again the first stage to identify new needs and issues that must be sorted based on results in the last stage. The tool has 3 main documents. First, the toolkit proper, with all the guidelines to support the planning cycle to improve in people-centered integrated health services. Second, a booklet of practical activities and tasks to complete all the activities required to complete the planning cycle. And last, an addenda using a list with many interventions that may be taken into account, and several of the interventions we had could really increase. I know that this is a busy slide, but in summary, the tool includes 5 modules. The 5 are directly reflected in the 5 objectives mentioned. The first helps to prepare for the evaluation and inclusive and participatory planning process. The second, to prepare and conduct the situation analysis and document outcomes. The third gives orientations and activities to help to establish or set priorities related to PHC based on the first module's outcomes, and includes all stakeholders identified in the first module. The fourth is organized and includes tasks to identify and plan the interventions to be implemented, with a task to develop the implementation plan. And the last module focuses on monitoring and evaluation and learning. As stated yesterday, the last module completes the activities with the conceptual framework measuring PHC as shown yesterday, and we can also additionally use some of these tools mentioned also yesterday. The most relevant in this context for local planning would be the subnational survey, focused on assessing governance, adjustments, population health needs, and some elements from the healthcare model geared to PHC, and it could include surveys in the different facilities and assesses design, organization, practice, and community participation, but also evaluation of systems and mechanisms to improve the quality of services in the facilities and resilience of the facilities and services. The last survey mentioned, and might be relevant when we consider the monitoring of this planning cycle in services, would be the patient and community survey to assess the quality of care and hurdles using perspectives and experiences of patients and non-users directly. Well, I was fast. Just to say that, as I mentioned, the tools should be visualized and completed. If there are questions or comments or interest, well, very welcome. Thank you for your excellent presentations. The country advisor approach is very important to us, because we don't want separate frameworks, but a framework and a work program perspective from WHO that suggests applying certain tools to solve the problems of countries, but not focusing on tools per se. Well, I am the bad cop again, so excuse me, Sergio. I wanted to be the good one. We don't have much time, so the floor is open for a Q&A session, particularly for countries who haven't been able to share their experiences. Julio and somebody else, Cristobal, please be brief, because we have a parallel event at the Radisson. So, please, Julio. Can you hear me? I first want to thank you all The experiences are extremely interesting. Adriana, I will comment and ask Juan Pablo and Ernesto a couple of minutes because I'm going to touch upon two topics. First, Sergio's presentation with information about the use of tools, and then the Bolivia experience that I think is so important. Sergio, because of what we heard yesterday from the Vice Minister of Bolivia, it would be important to include Bolivia in FAS, because in your slides it isn't included, and it's one of the few countries where they have reached phase 3. And this has been a very participatory and broad process that has an improvement plan after the assessment. And Brazil, where we're working and that didn't have any intervention. And that is also important because surely Brazil is one of the countries that has implemented more tools, but then don't have the same names we use. And I think we all agree that countries shouldn't necessarily implement PAHO tools, but rather intervene in the elements that have to do with governance, financing, the model of care. And I say this because probably Brazil is a country that has implemented most essential functions, and for 20 years. But in the past 3-4 years, they stopped doing it, and it is only now, and Ernesto and others know, we're just adopting the Portuguese tool. We just launched the virtual campus tool for essential functions in Portuguese. And I didn't want to enter into that discussion because I've seen these things happen. But I also said it taking into account what Felipe Proenço, who's here from the Ministry of Health. In Brazil, I have been traveling half of the states of Brazil in the past 6 months, and it's probably one of the countries where we have more integrated networks using PAHO tools. But they don't give it that name. They call them macro regions or regions, and the process is called regionalization. When I heard about it, I said this isn't an integrated network, but Brazil, as other countries, legitimately requests tailoring methodologies, including sometimes a name change. So after clarifying this, I wanted to pass on to the second point, and that is to survey the Bolivia experience in a very special context. And I think that has been successful.
And it is not based on the implementation of tools, which has made noise for everybody, I think, but you corrected that noise of talking about tools by saying that tools per se are an intervention, a complement, and that what you want is to transform the health sector, the health system. In Bolivia, when I arrived there in 2018, there had been 10 years training and risk, one after the other, but there was no risk. Basically, because the tool was implemented without considering how unlikely it was that it was sustainable without a systemic process. In Oruro, for 5 years, a process of transformation was implemented, including the implementation of all the tools, but together with a human process, because what we've got to do, as Brianna says, is repetitive cycles that measure transformation. Because implemented risk, training people, then go to another municipality, as has unfortunately been the case in many countries in the region, is not sustainable. So I would like to mention that that Oruro experience was possible because we chose a territory where there was a government unit. there were resources of international cooperation, $3 million, and initially they were going to be destined to the implementation of primary care packages, mother and child, etc. We turned that into a project to transform the health system based on governance and stewardship, including planning, strategic planning, the incorporation to the single health system, the SUS, in 2019, and measurement of networks was not how many workshops we carried out or how many assessments we carried out, but critical indicators. After 4 years of intervention, the out-of-pocket expenditure went down to 17%. There was an increase in access to treatment of non-communicable diseases with hearts with MHCAP. And finally, Diana mentioned it, we cannot not measure our intervention on people. We made 4 representative surveys of the whole population. There was an improvement in satisfaction and access, and basically a decrease of the gap between the rural and urban areas. Thank you. Yes, it's time for only one intervention. And you already saw Cristobal? No? It's not the last chance. I see another hand there, but it's... Oh, I'm sorry, Alejandra. Just 1 minute. Because we have a parallel event, and I will tell you some details that will come. Fetch us. Thank you very much, colleagues. I want to thank and value this panel. I think it has been very interesting. Thanks also to Julio for telling us about the Bolivian experience. My name is Cristobal Cuadrado. I am consultant on health systems and services in Bolivia right now. I have following the work where Julio carried out before, where the essential functions have been very important, where after 3 years we complete this cycle with actions of strengthening, and we have achieved a state in which subnational level wants to advance in self-assessment of every department in Bolivia, and they want to have the national process as a starting point, and the national level also wants to facilitate that subnational effort. That shows how a systematic effort of technical cooperation, which starts with making sense of how that instrument may change things and involve actors, may become a long-term change factor that has survived changes in government, and that should be valued. A second point I wanted to mention, and Julio also mentioned it, is the importance of working with specific territories with an integrative manner. And what we're working on now, following the Oruro experience, we want now to move to Chaco, the Bolivian Chaco, a region that has many needs with interculturality, lots of rural people, poverty, with health indicators that are very poor. And we want to stress the mobilization of tools from different areas of PAJO, the HATs, the strengthening of epidemiological capacities tools, where each unit with a logic of systems and services may provide tools and capacities to local governments, understanding that the first mechanism of mobilization is direct technical cooperation, mobilization of experience in the communities, within the country and between countries. And that is something that we should consider as an organization. It has been well shown in the colleagues' presentations. Thank you very much, colleague. They're calling me from the State Department. Well, I trust Alejandra. We'll leave it for later on. Thank you, Alejandra. Thank you very much for all your comment. I agree with all you say. The focus is not on the tools. They are a means to an end, which is cooperation to support countries. And these tools that we have commented can be adapted to context. And the idea is that they do adapt and that they reflect what the country needs and not just to apply a tool. I fully agree. For midday, we'll have a parallel event about economics and health in the Americas. It's a State Department initiative where PAJO and IDB are part of the technical secretariat. This is by invitation only. You have received invitations by email, but if you have any doubt about the status of invitation, you may contact Daniela Zuluaga. I don't know where she is now. Well, Daniela will be there at the door if you have any question, and there will be some vans that will take us to the Radisson Hotel, to those who are invited. And thank you very much, and we'll meet again in the afternoon.
Hola, buenos días, buenas tardes a todos y a todas. Muy bienvenido al taller 3. Gracias por acompañarnos, por su dedicación y compromiso a esta hora en la tarde, el tercer día de la conferencia. Si podemos tener la primera presentación, por favor.
Hello, my name is Silvana Luciana. I belong to PAHO in Washington, and I work in non-communicable diseases. In this workshop of an hour and a half, we're going to discuss at length the non-communicable diseases in PCH. We're going to follow up when we started yesterday with a workshop in the morning, sharing ideas and promoting our tools, which are available through PAHO or the member states, exchanging experiences and seeing what's happening with the various countries in relation to non-communicable diseases in PC, in primary health care. In this session, I'm going to start revising the new PAHO initiative to improve care for PHC.
De caso, uno por Dr. Charlie
Then Charlie Otero will make the first case, which is in charge of transformation in health and digital health. Then we're going to have Daniela Romero, who is an economist from the World Bank, and he's going to be talking about mental health and the work the World Bank is doing in this region. And then we're going to have some experiences in Jamaica by Jacqueline Bisor Mackenzie, who is the Chief Medical Officer of the Ministry of Health of Jamaica. And then lastly, the experience in Uruguay with Dr. Marcelo Lenz, an initiative of telehealth in Uruguay. So we hope that we can all learn something new and that you get inspired to apply all that in your working places. Just to remind you that non-communicable diseases are the first causes of death in all countries in Latin America and the Caribbean. It is responsible for 81% of all deaths in the region. This is the ranking of countries per mortality of non-communicable diseases, and you can see that there is a large range of mortality rates in the countries. And there you have Uruguay, which is in the red arrow, which is in the middle of this ranking. Differences are not only involving health determinants and the risk of non-communicable diseases,
de salud para atender
but also the different capacities to care for non-communicable disease patients. This is what we want to touch upon in this meeting, how we can improve the diagnosis, treatment, and control of non-communicable diseases. At global level, we have agreed on some goals and some initiatives and how to reduce them by a third by 2030. Around this global goal, we have some goals to reduce risk factors and also to increase access to treatment and medicine for hypertension, cardiovascular diseases, to reduce the increase of diabetes and primary health care. And how we're going to get to those global goals? Well, we have a package of the best investments to deal with non-communicable diseases. It's a package that includes public policies to reduce risk factors for tobacco, including taxes, neutral packaging, or to reduce the prohibition of advertisements in alcohol or similar interventions through public policies and reduce access and dangerous consumption.
acordado que
As regards the diets, there are also public policies to reduce salt and trans fats and others. And for physical activities, public policies so that the population can be more active physically. And lastly, there is a set of interventions for primary health care, which is investment including screening, diagnosis of the main diseases. At PAHO, we have a regional strategy to attain these global goals and to implement all these activities. And this includes interventions to improve policies to manage non-communicable diseases and surveillance, as well as reduction of risk factors. But I would like to deal with the management of non-communicable diseases, which is the best care in PHC. And at present, this is what we're going to be dealing with. The gaps that we want to attack are because we know that there is a high proportion of people in all our countries that are not well diagnosed, don't receive good treatments, and are not controlled. Yesterday, in the non-communicable disease workshop, we could see that in some countries only 25% of people suffering from hypertension who are being treated for that disease. And that is very risky for cardiovascular events. Also, we have to have a follow-up of the data, and we have to create information systems and have information available for the surveillance and monitoring and diseases, insufficient access to medicine, and particularly human resources.
Es lanzando una nueva iniciativa que fue presentado en el Consejo Directivo en septiembre para mejorar la atención en las enfermedades no transmisibles dentro de la atención primaria de salud, fortaleciendo las capacidades que tiene a nivel de los ministerios de salud para la planificación y implementación de servicios integrados, pero también para aumentar la capacidad de los recursos humanos y los servicios para asegurar que todo el continuum, desde prevención primaria hasta control y cuidados paliativos, están integrados dentro del paquete de servicios de salud. Y por último, fortalecer la parte de vigilancia e información. Y como Dr. Hennes presentó ayer en el taller de enfermedades no transmisibles, esta nueva iniciativa está abarcando todas las enfermedades no transmisibles más comunes, ¿no? Como enfermedades cardiovasculares, diabetes, cánceres que son detectables por tamizaje como cáncer cervicuterino y cáncer de mama y cáncer colorectal, y también para los respiratorios y la educación en salud para consejería para las personas con enfermedades no transmisibles. O sea que la visión es que tenemos un paquete de intervenciones en la atención primaria de salud que pruebe los servicios en un patient-centered approach, o sea que la persona en su totalidad, considerando todas las enfermedades no transmisibles más comunes, ¿no? Y las áreas estratégicas que estamos trabajando para implementar esta nueva iniciativa empieza con hacer una evaluación de las necesidades en los territorios, en las áreas de salud, para ver cuáles son las brechas, las necesidades en los servicios, en las comunidades, para realmente ver cómo podemos mejorar la integración de enfermedades no transmisibles. También queremos aumentar la participación comunitaria para que la gente en la comunidad identifiquen cuáles son las prioridades para ellos, para que ellos se participen en los programas de tamizaje, que hay un autocuidado, que hay más información, consejería, que hay esta participación social, ¿no? Y prescripción social que sabemos que se requiere para mejorar la atención de personas con enfermedades no transmisibles. Luego tenemos las guías y todos los protocolos, el desarrollo de personal y la capacitación que sabemos necesitamos para los grupos interdisciplinarios en la atención primaria, la ampliación de medicamentos y tecnología y por último la mejoría de información y seguimiento. Bueno, y por la parte de la planificación de las intervenciones a nivel territorial, lo que estamos proponiendo es que utilizamos este marco de la OMS que hemos escuchado mucho durante esta conferencia, ¿no? Que es para ampliar la atención primaria de salud, tomando en cuenta el framework, ¿no? Este marco como referencia, todos los insumos que se requiere para ampliar la atención primaria, todos los procesos que hay que enfocar y los resultados en salud que queremos lograr, ¿no? Y para enfermedades no transmisibles, lo que esto significa es que hay más compromiso y liderazgo, que enfermedades no transmisibles, que es la principal causa de muerte en todos los países, esté ahí como el centro, la prioridad principal en todos los planes nacionales de salud, que hay las necesidades de la población bien identificado, que hay una financiación adecuada con infraestructura, proveedores de salud, medicamentos y sistemas de información bien establecido. Yo sé que esto es un como gran reto para nosotros todos, para asegurar que estos insumos y procesos están ahí dentro de los servicios de salud, pero esta es la visión y la ambición que tenemos, ¿no? Y por la parte de participación comunitaria, desarrollar.
As regards community participation, we have campaigns, strategies, educational materials about non-communicable diseases and community participation. As regards guidelines, we have guidelines for the most important non-communicable diseases, and as regards human resources, we have training courses addressed to the personnel in PHC in various topics. These courses are available through the PAHO platform in the virtual field. This is free of charge, and we invite you to get to the virtual campus of public health to have access to these courses. And then there is an excellent resource, which is a group of the demand for technologies of non-communicable disease. We have packages for each main disease, including not only medicine, but also technology for diagnosis. This is a strategic fund that is available for all the ministries of health with very affordable prices independent of the quantity of the medicine required. And just to conclude and give you a context to this workshop, I would like to focus on the need that we all have to expand the integration of non-communicable diseases services in PHC, mapping the capacities and needs, and to improve all the guidelines that we have through the PAHO and strengthening information. So thank you very much for your attention, and we continue with the next presentation. We were going to focus on this information component. Dr. Auditorio will be talking about the initiative of PAHO about telehealth and non-communicable diseases. Charlie, the floor is yours.
Hola. Bueno, muchas gracias a
Thank you all, mainly for giving me this chance to address you all. It's good to talk about telehealth, particularly in Uruguay. And that's why I took advantage of the local people to show you how we are working from PAHO to help countries to mature and implement these telehealth programs. Although we know that there is a difference between the key concept of telehealth, teleconsultation, teleassistance, we like to talk about telehealth and not to focus it on a medical process, but to focus it on tools for the team. This tool can be used by the entire team, and we want that dynamic to be used in all countries. That's why we are using this name to introduce you to this program. Although we talk in Asilo Anatolio, we have developed a platform that we call All-in-One platform. It's a program that provides several resources for countries, once again, adopt them as flexible as they want, because that's the way it's been thought out, so that we can benefit from all the resources that PAHO has provided for countries to improve and take advantage of. We start with the support from our office. Others mature on the basis of the tools that we give them. And there are several components. There is a platform of telehealth where you can have video conferences using open source or open code tools, but there is also an electronic health record. There is a component infrastructure, education, and support, which will be seen very quickly now. The telehealth module is developed on an open code system. It's a digital public good. This means that countries can adopt it without there being any need of paying licenses or having resources for these for this initiative. The idea is to standardize ideas. Patients have been recorded digitally, and they have learned how to contact their professional through WhatsApp, through Zoom meetings, through any tool that they may have got access to. So let us start formalizing these processes and integrate them so that they can be used in the best way possible according to the workflow. So this platform is built on an interoperable module. This means that it can be adapted to the processes that are already in place in the countries. If they have an electronic record system, they can use this to do away with Zoom or WhatsApp. And if they haven't got a digital tool for clinical digital clinical records, they can use it as well. This tool, the electronic health record, is a tool that we've developed with all departments in our institution. We understand that our focus had to be on PHC and non-communicable diseases. On that basis, we created an electronic record as dynamic and easy as possible. In fact, once we see the various screens, you'll see how easy it is to use. The main goal is that it can be implemented very easily with low technological requirements so that care processes can be fed and improved by having all the information. This is what Silvana was telling you, having information about what happens with our patients, with their chronic diseases, how they manage their chronic diseases, is included, we believe, in a very dynamic manner to obtain all those data instead of having to make an extra effort to record and to make follow-up, on the other hand, to devote the time that they need and generate knowledge base that we need to manage health. So this is included in a care system in the platform where we have tried to structure and codify and represent in standards what we are recording about our patients so that that information may be retrieved and used later on. On the other hand, as we saw it earlier, the telehealth program that we thought of is supporting countries in terms of infrastructure. Those countries that started right from the beginning this program received infrastructure in order to obtain data remotely. And that's how we could distribute not only the classic tools for care, like computers, notebooks, or tablets, but we've also provided several devices that were thought out and designed together. We call them telemedicine kits. But they were used and thought for non-communicable diseases, tensiometer, balance weighing machine, measurement, and some had even digital tensiometers and echographers that have allowed us to move forward jointly in this process of care. This doesn't mean that countries need all these telemedicine kits to move forward. It means that if we can support you there, we will. The idea is to start thinking how it works, what the benefits are to be provided. Together with this definition of the equipment, we have also thought about the minimum equipment that every center or every institution needs to start maturing. Once again, none of these requirements are compulsory to implement telehealth. However, since some guidance is necessary, we have thought about what equipment is necessary for a PHC or for a low complex center, or what equipment is necessary for a reference center. And that's how we've gone about every information center. And all this is available so that you can have access from the ministries, from the countries, and even from the regions. Together with this, we're thinking about a program that is focused also on training of the health team. We also have a virtual course in our virtual campus with over 50,000 students enrolled. And we also have many other courses focused on teams implementing telehealth, including the introduction to interoperability standards, information systems, how to prepare a health system, how to manage and deal with change from the implementation up to the work with patients. And all this is located in our campus and accessible to everyone. Something else to be highlighted here. As you know, campus is an open tool. Not only people in our region have followed our courses, but it's done globally. There are many, many students that don't belong to our region. That shows there was a need to move forward in that area. Those of you who like to play or who like games, the course is based on verifications, a simulation course. So either because you're interested in telehealth or because you're interested in games, well, you can have access to that.
The other thing we did is to make available for the countries that a series of support tools that have to do with a tool that will allow institutions and countries to measure the level of maturity so to know which are the aspects they need to prioritize. And second, tools for an implementation that go from a training equipment for the implementer, those that will be carrying out the project, but also a support team for the health teams that will start using the tool. The tool, as I say, is an open source tool that is flexible and scalable and can be parameterized, and we have a support area that can support countries and regions in those specific needs that they have, so that they can record and adapt the tool to the healthcare process and the follow-up and monitoring, because you know that as any tool, if we don't measure and monitor how it is being implemented, we will not have true knowledge of whether we are doing things right or not. So in this first option, I've given you a general view of the tool, but if I have 2 more minutes, I would like to show you a short video so that you see that the platform exists and it works. So let's see if we can watch the video.
Hola, Fernanda.
Hello, Fernanda. Good afternoon, doctor. How are you feeling? Okay, a little hoarse. Can you hear me well? I'm going to write you in the chat. Perfect. Why are you consulting today? I started with a bit of a dry cough this morning and I got hoarse. So you started today. Did you have a fever? Any difficulty breathing? I had no fever. I had no cold symptoms. I only started with a cough and I lost my voice. Are you taking any medication? Do you have any disease? No, I don't have any disease and I don't take anything. No earache, just a sore throat. Just a sore throat and very high dry cough. Good, perfect. I'm going to prescribe a painkiller so that the pain in the throat is reduced. And if you start with a lot of fever and the symptoms are go in 48 hours, you can do another teleconsultation. And I will leave the prescription here in the system, and you will receive it in your computer or cell phone where you're connected. Just a minute. Okay, I've already loaded the prescription. And finally, what I'll do is I will record this consultation on your medical record so that if another doctor treats you, they already have the information and they know what has been happening to you. Perfect. Now we can stop it. The idea was not to go over a long time, but just to show you that the platform is working. There are lots of countries that have installed it, and they can use it to mature the telehealth projects, or also as a transition tool as they go about with the local developments, which we know a lot of you have. And so we are available if you have any questions. Thank you very much. Excellent. Thank you very much, Charlie, for showing this all-in-one platform. And we invite you to approach Charlie if you wish to adapt it or use it in your clinic or country. And now we will continue with the program, and we will go to the topic of mental health, which we know is a crisis. So we will invite Dr. Daniela Romero to present what the World Bank is doing with a mental health study. Daniela, the floor is yours. Okay, good afternoon, everyone. It is an honor to be here sharing with you the work that the World Bank is doing on this topic. My objective will be to present the action lines that we have been supporting and share some findings and results of a preliminary study that the bank carried out towards the end of 2022. To tell you about the context where the bank designed the strategy for support to mental health, we saw an increase in mental health conditions, especially related in relation with abuse of alcohol and substances and suicide attempts. And this has also has to do with the increase of the figures in this respect that went to 0.5% to 0.8%. And we have seen that the COVID pandemic increased the incidence of the mental health conditions in a context of restrictions of limited health care and funding. And this starting point talked about low funding of mental health and at the same time an inefficient expense that was highly concentrated on hospitals. In this context, the bank launched a series of analytical and counseling studies in parallel with the funding options they have for those countries that request the strengthening of the health systems. Particularly recently, they have launched a regional study to identify the situation of mental health in the region of Latin America and the Caribbean, focused on providing funding, among others. And we have had case studies to identify the challenges, structural challenges, and provide technical assistance in a set of countries. And we have also launched strategies for dissemination and innovative strategies to strengthen healthcare in the framework of mental health. And the idea of this space is to share very quickly this regional study that is called Funding Mental Health in Latin America and the Caribbean, and that was carried out by Amparo Gordillo Tovar and Andrés Medicini and psychologist Catarina Dahl. The objective was to get to know the profile of funding and expense of the countries of the region in mental health between 2019 and 2021, and to analyze the response before the needs that were imposed by the pandemic to approach these conditions, and also to study the payment mechanisms that are used for carried out these studies. This is a qualitative and quantitative study that was consisted of a survey to the ministries of health and central departments. The coverage of the study is broad because it encompasses 88% of the population of Latin America, obtaining responses from 23 countries. It had been launched in the 41 countries, but the rate of response was only 41%. Analyzing by region and the countries of South America, with 40% was the biggest one, and followed by the Caribbean and Central America with 26%. It's important to highlight that one aspect that the countries mentioned was the difficulty of having information, financial information and health expense information, because the data was not available or because the level of aggregation was not detailed enough to obtain this information, which indicates a first hint of where the country should start working to have an idea of the starting point and take the informed decisions about how to progress concerning financial efforts in these areas. I will now present the findings with a focus on aspects of primary health care. I will not give the conclusions of a whole study. The first place, what we identified was that the governance of the countries improved for mental health care in the last few years. 87% of the countries have a law or legislation about mental health, and 78% has some sort of policy, a plan or strategy that is focused on mental health. Most of the countries focus on the governance and responsibility that is at the central level. But what we have seen is that even though many have advanced with these frameworks and strategies, only 35% of the countries incorporate estimations of the human resources or funding that are necessary for these policies. A positive aspect that shows a commitment of our countries toward achieving universal coverage in mental health. It indicates that in a greater or lesser measure, there is an offer of all the mental health services throughout the system. 78% of the countries declare that this is done mostly in the public sector. When you analyze the type of services, you see that there is a big coverage of primary health care, followed by hospital and specialized ambulatory services. But there are there's a lack of community-based services and early attention and prevention. And it's important to consider that once a person arrives to the healthcare center, this is late. The system must seek them so that they can protect the mental health of the population and prevent them from reaching our healthcare centers. Very aligned with what we said before. When we see where the funding is, the countries say that it's mostly dedicated to hospitals and specialized ambulatory services. So in lesser way, we see public funding for community services or multiple environment services and institutions that work in promotion and prevention. Another positive aspect, when you look at the type of mental health condition, you see a broad coverage of public programs, but we also identify a gap within those programs or in parallel programs to approach promotion and prevention. And we have seen that countries have an important development concerning the programs to prevent suicide attempts and maybe those that are more focused on abusive use of alcohol and drugs. And when we see the existence of protocols, we see a more heterogeneous response. Very few countries have implemented these guides, and it's a broad space for improvement. There is a broad coverage of drugs and psychotropic medicines that are available for families, be it through funding or provision. Connected with the previous presentation, what we can see, and I will change the topic to talk about telehealth instead of telemedicine, following Charlie's advice, is that the penetration of telehealth is low. And when you see which are the services and the type of institutions that they use, is a greater utilization of the institutions, hospital type and emergency type, and ambulatory consultation services. And we see a low participation of other types of institutions, such as community services or residential services or psychosocial rehabilitation centers. When you analyze, but what kind of telehealth do these countries or these institutions use? So, and what we see there is a greater penetration of the electronic medical records and maybe remote training to health specialists. But we see very low utilization of telesurveillance services. And this is very important because, as we will see, the demand is very high and there's a lot to cover. On the other hand, and as a positive aspect, we have identified that the countries in our region implement a broad range of interventions to better coordinate mental health services with primary health care. We have seen that what they mostly develop is in liaison consultations. The first level doctors, if they have a question, they consult with second level doctors, and another type of specialized consultation is training and supervision monitoring by specialized doctors in the second level. And in the third place is the review of a pre-selected case by this group concerning the cases that are approached in the first level of attention. But what happened during the pandemic, what the countries have informed is that precisely as many of you know, the demand for mental health services has increased, especially in the case of common mental disorders and drug use and behavior disorders. But what is most important is that there was an increase of unsatisfied demand, unmet demand that improved in the second year of the pandemic, but is still high. One important point, when you study the causes, you see a set of factors. On the one hand, respondents say that there is a lack of information by the population concerning the availability of these services. And there are factors related with economic barriers, the cost of transportation or geographic barriers, and the remoteness of these centers, and the lack of sufficient funding to cover this unsatisfied demand. So what did we say? Unfortunately, that the mental health is still underfunded, and the data that the 78% of the countries declare that mental health is mainly covered from the public sector. This is centralized in national or central budgets, which represents only 2% of the public expense on health. And this, in the case of the Caribbean countries, whose participation almost doubled. In other countries, it has stayed the same or gone down. And at the same time, we still see what we had seen at the beginning before we started with these studies. But mental expenses, public expenses on mental health is concentrated on hospitals. As we see, leaving aside the case of South America, where there is only one country that responded this block, most of the expenses are concentrated in hospitals. And along the same lines, when you see the type of services, you see that it was approached mostly for tertiary and secondary level services. One positive aspect that maybe the pandemic made a contribution to give a bit of space to is that expense has been doubled in primary care of mental health, because it has been doubled in the first year of the pandemic, and in the second year, even though it was reduced a little, it stayed above pre-pandemic levels. And so, to recap, what do we see? Even though mental health is still considered a priority area, and this was empowered by the pandemic, this did not bring greater funding. Countries recognize that funding of mental health is insufficient, and that this could be organized in a more efficient manner. However, there is no possibility seen of increasing the funding in the short term. And what we have seen that these improvements in the governance framework and the reforms of the system have not brought along a change in the mechanism and the amount of the funding that is devoted to this topic. So what are we seeing? On the one hand, the demand has increased and satisfied demand is still high, and we are in a financial restriction process, and that does not look like it's going to be modified in the short term. So this requires the modification of the health system so that we can increase the resolution power of the first level. And these conclusions show that there is a lot of improvement to be made in different areas. For example, to invest in promotion and prevention, there is a space to invest on community spaces. The penetration of telehealth is very low, and we need to reach higher percentages of the population. So there are a lot of challenges ahead of us, but all the elements are there so that we can move forward. I don't know if I have a bit more time, but I would like to tell you very quickly what we have found in the case of Uruguay, which is the country that is hosting us now.
We've identified, on the basis of one of these case studies as regional study, a case of well-trained human resources. On the other hand, we've seen that there is a scarce adaptation of syllabi for undergraduate and graduate courses to introduce what Uruguay is carrying out. There is a continuous education program that could allow, if existed, the staff to carry out their work. And it's difficult to identify the situation. On the basis of this diagnosis, together with the National Mental Health Program, was to design a training strategy for primary level care. We worked on training trainers. We carried out the first training sessions through the intervention ways, MH gaps that you must have heard of through WHO. We have received information that this strategy to train the staff is already meant to reach the entire staff. This is what I wanted to share with you, and I hope this has been useful. Thank you.
Muy bien, muchas gracias, Daniela, por mostrar los.
Thank you, Daniela, for showing the results of this study. This makes us think that we have to reinforce all services in PHC, and particularly funding. Thank you. The next presentation will be in English.
And how Jamaica has integrated NCDs, including telehealth for NCDs and primary health care. And I'd like to invite Dr. Jacqueline Bessasor-McKenzie, who's the Chief Medical Officer of Health in the Ministry of Health in Jamaica, to present on the case of Jamaica. Thank you.
Thank you. Good afternoon. I will speak in English because I do not speak Spanish or Portuguese. Okay, so I want to thank the organizers for inviting Jamaica to share how it is that we are approaching the reform of primary health care to manage NCDs. Jamaica has a history of a strong community-based primary health care system. In 1978, we were able to showcase at Alma Ata a network of health centers across the country that were so positioned that there was a health center within 5 to 10 kilometers of every home. And that came with a cadre of community healthcare workers from as early in the 1960s that were able to reach into these communities. So we presently have 325 primary care facilities, which is spread across the 11,000 square kilometers of the island. and this service was really based on the needs of the time. Fast forward to over 40 years later, and what we see is a change in epidemiology and demography, as has been depicted by so many countries here over the last couple of days. Our population is getting older, and what we're seeing is that there is the epidemic of NCDs that is just growing. And our highest mortality now is coming from cardiovascular diseases. So NCDs are our new priority, and so therefore, it is essential at this time that we look at a reformation of our primary healthcare system that allows it to meet the new demands of the population. And like other countries, we face the fact that because our health centers, although adequately spaced, does not have the resources that persons are bypassing the primary care facilities, and they're flocking to the health centers, to the emergency departments, and of course, they are accessing a higher cost care, because you know that once you step into the hospital, the cost is so much higher than when you step into a primary care facility. So what we need to do in terms of reform is to look at how we address these gaps, just like how other countries have said. But it's not just in terms of the clinical care, that first level of clinical care, primary care, but also the other aspects of primary health care that the system has not adequately developed in terms of addressing risk factors, the social determinants of health, that needs to be built out within primary health care to be able to combat NCDs. So prior to COVID-19, we had contemplated these issues, and in 2019, we had produced our concept for what our primary health care reform should look like. And we had published this document that documented what our concept was in terms of how we wanted to reform primary health care, looking at the gaps in terms of infrastructure, in terms of staffing, and also looking at the scope of services that were offered in primary health care to ensure that we were now addressing the needs. So in terms of the reform, it addresses just the same issues: infrastructure, human resources, and also, most importantly, digital health transformation as to how it is to make our system more efficient and to increase access. So our reform is looking at expanding the scope by introducing new services, such as specialist services to deal with the problems associated with non-communicable diseases, and also looking at palliative and rehabilitative care. Under the reform, we're taking a comprehensive look at all the services offered in primary health care. And I noticed that the previous speaker spoke about a deficit in the number of persons for the mental health, to meet the mental health needs. So we are looking at all the services that are presently being offered in primary care and those that are to be offered, and to say what it is that that service looks like, what it is that is going to be provided, and therefore what is the resources in terms of infrastructure and in terms of human resources that are needed. We're really approaching it from the bottom up to determine what this service is, so that we can, of course, get the financing for this. And this is how we're approaching developing our human resource plan for primary health care. And we have prepared what we call microplans for each of these services that look at that workforce plan. And already we have completed the human resource plan for physicians that we have tabled and presented to the Ministry of Finance. And we have now, this year, gotten the approval for 700 additional physician posts in both primary and secondary care, just by taking that step from the bottom-up approach. You know, people have spoken about how do we approach the Ministry of Finance and get the agreement. And one of the things that we found out early, the Ministry of Finance said to us, Ministry of Health, you keep coming to us and asking us for more. But if you can tell us what that entire picture looks like, then we are better able to accommodate. And we guaranteed, 3 years ago, they said to us, we'll guarantee you that we will give you what you want if you can tell us what it is that your big picture looks like. And in presenting the physician workforce document, which added approximately 10 billion Jamaican dollars or 63 million US dollars to our budget, we had that number of persons approved just this year. So in terms of the infrastructure needs, we are now looking at assessing, because we are planning to upgrade 125 facilities to be able to offer 3-tiered services: community, district, and comprehensive health center. Now, we have started the upgrading of 10 primary care facilities, and we are doing this in conjunction with the Inter-American Development Bank, the European Union, and the government of Jamaica. This is under a health system strengthening project. This is a very comprehensive project that looks at all different areas to say how it is that we, from a broad view, strengthen our response to non-communicable diseases. The HSSP project has both a policy and an investment component. And I heard another speaker speaking about that in terms of the development of key policies to address NCD care. There are policies for mental health, policies for alcohol use, the promulgation of the tobacco control bill. Different aspects of NCD care were included in the policy part of the loan. And then the investment part of the loan looks at the infrastructure build out in 13 facilities, 3 hospitals and 10 health centers. Again, emphasizing the idea that you need one to support the other. You can't just think of primary healthcare facilities, so we looked at a network, a hospital, and the health centers that were around the hospitals to make sure that there was a collaborative approach. Under the support of the project as well, we're advancing universal connectivity through an upgraded ICT infrastructure, targeting 100% of public hospitals and 25% of primary care facilities to put in place the infrastructure and the networking so that we are able to have internet facilities. We are introducing electronic health records under the project, and last month in November, we had our go live for our first hospital, and in February of 2024, we will have the go live for our first health center. Apart from the electronic health record system, the project is also seeing the development of policies. Again, that very important groundwork that needs to be built in terms of a national plan of action for information systems for health, policy guidelines on personal health protection, and the Ministry of Health is strengthening the IS4H governance and revision of the IS4H strategic plan and the activation of an information governance committee. Other digital technologies have been introduced in primary health care over time, and we are looking at ensuring that there is interoperability between the different platforms that we have. Our goal is to achieve a people-centered, clinically safe, integrated, interoperable, agile, and resilient, and secure digital health ecosystem. The primary healthcare reform in Jamaica is not just looking at quantity, but it's also looking at quality. It is urgent that we look at how we offer services if we are to ensure that the investment that we make will in fact result in resilience and will have an improvement in health outcomes. We are reorienting the system towards integrated care. We're trying to break down the silos that have been created by implementation of vertical programs and reintegrating some of our services. We're looking at the quality of the interaction with our clients by promoting good customer service, equity, and preservation of dignity for all persons. A change in culture is required, and we have a robust change management plan which is to be implemented. We are looking at increasing the capacity of our healthcare workers to deliver health promotion and education messages using a life stage approach to our clients. Our aim is to improve the health literacy and health-seeking behavior of our population. We're now creating a life stage approach to health promotion and education training module where key health education and screening messages pertinent to every life stage will be provided to clients at consultations. In conclusion, I believe that we are set to make significant changes to to create a more robust and resilient primary healthcare system in Jamaica that will be able to address the needs of NCDs. Thank you.
Thank you very much. That was a very comprehensive example of what government commitment to financing and strengthening the health system to ensure NCDs are at the forefront of health system strengthening, and also the commitment to telehealth and to health human resource strengthening. So congratulations, thank you again. And I'm sure there's many, many questions from the audience on lessons that you've learned in this journey of primary healthcare reform in Jamaica. So we're going to conclude with our last country example. We're going to be here in Uruguay, and I'd like to invite Dr. Marcelo Lenz to talk about telehealth here in Uruguay. Please. Oh, y vamos a hablar en español ahora.
And now we'll be talking in Spanish. Can you hear me? Okay. I will tell you very briefly about the telehealth projects we are working with in ACE. I'm a doctor. I'm a specialist in administration of health centers, and I work in the first level attention in ACE, and this is a team made up of Daniel Estroza, Melina Gil, Juan Gil, Estefania, who must be around there, all of them. I want to thank them because this is a work of a team that I'm only representing. Okay, so this to give you a context of what ACE is, the administration of health services of the state, and I think that Mr. Cipriani, who is our chairman, was here, and this is a greater provider of health care in Uruguay. It's a public organization that attends a population of 1.4 million users, so we're talking about 40% of the population, which has obviously its complexity. We are throughout the national territory with 884 healthcare centers that are distributed, as you can see in the chart, 800 units in first level care centers, 24 of the second level, and 19 of the third level. We all have other special centers that are rehabilitation centers and homes, and we also provide care and also the service for people deprived of their freedom, and we also work there. This organization has 30,000 workers in the whole territory of the country. Why telehealth telemedicine in ACE? These are the advantages that are characterized for each group, which we have. You probably all know them, but it's good to see them again. For the users, what we seek is greater accessibility, greater resolution. And this should be mentioned that the reference and counter-reference system between different levels of care is not completely optimum, and telemedicine provides a great opportunity to adjust these reference and counter-reference processes between the different levels, and so that they start working together, approaching patients, as I will mention later. Obviously, we have improved the level of care. And for the health team, this is a continuous training and update and teleconsultation with a first level doctor and a specialist is a time that is not just for solving the patient's problem, but there is also an exchange of knowledge between the specialist and the first level doctor. And this is fundamental. They work as a team and they approach the patient's problem together. This is learning at the first level that is absolutely fundamental for us, and it improves the relation and of the barriers that exists between the different levels. For the managers, there is greater productivity, greater use of IT systems, and in the project that we have deployed, we are using institutional systems that ASE has, and the ambulatory health records, and the system of management of consultations where we handle our schedule in a virtual manner, and video platforms of which we are using Zoom, and we are making some own developments so that we can have the video embedded within the electronic health records, which will make the professionals work easier. And I would like to add one more element that is not there, and why telemedicine in ASE. And this is, some colleagues have probably mentioned this, but we are at a hyper convenient time for the development of these types of care. First of all, because we are coming from a pandemic that made us have provide services remotely, and because the technological capabilities are available and the use of technology in different places that make it extremely convenient. And this is clear for the authorities and the Ministry of Health, and I think we are all going in the same direction, which is very good. Very quickly, just to tell you that these are 3 big projects we are working on. There's another one that is not here that was started last week, but these are the 3 big projects in telemedicine with an impact on the first level of care. And the one is a cooperation that we're working with the PAHO, that is tele-interconsultation of specialties, which I will talk about more deeply, a cooperation that we have with IDB for approaching mental health. And this is a project that we are about to deploy in the territory. We have all the protocols of the care processes, and we are about to start the training of the first level staff to approach mental health issues where we have the greatest incidence of suicide attempts and depression, and that's where we will be starting with this project. And there's a third project that is local, that is funded by the National Research and Development Agency, which is about alterations of development in children, which is handled by a national reference hospital, which is a Pereira Rosell. And I will tell you very quickly about the project that we have with the cooperation with the PAHO, which is the one that is more developed. And this seeks the implementation of 27 telemedicine positions in the national territory, 27 nodes of telemedicine in the country, in those places where we have the greatest difficulties for access. And once the demand, unsatisfied demand, is where we have the greater demand in these places, that's where we are implementing these telemedicine nodes. And it's not just the installation of the equipment, which I didn't mention that there are some suitcases that Charlie showed in a slide that he showed. They call them the telemedicine suitcases, so that the rural doctors can have available an equipment that can measure all vital parameters and the capacity to access electronic systems, and they can have a video consultation from the patient's home. But this is not, the technology is not the main thing. The main thing that we are seeing and has a greater results is training, and now I will tell you about it a bit. And the communication, we want users to own the telemedicine tool. We want our users to know that in their health center where they go every day, their doctor has a possibility of doing telemedicine, so that they ask about it. Well, doctor, what is this modality? How can I access? We're working on a propagation campaign for the health teams, but especially focused on users so that we can achieve this. And finally, what we have at the bottom that is cross-cutting to the whole project is a change management module. Why? Because some colleagues have mentioned this is a cultural change concerning the way we normally work. Even though in the pandemic we went to using completely tele-assisted services. Nowadays, we've gone back to the usual conventional system because it's implied in our organizational work culture. So for us, it was very important to have a change management module, and we've worked with a specialist in change management that has worked with the reference to make them understand that telemedicine is not a second-rate alternative, and it will not supersede in-person medicine, but it will strengthen it and make it more efficient so that the patient, when they get to the in-person situation, they have all the studies and that consultation will be much more effective. These are the briefcases that Dr. Auditorio mentioned. They have a point of care that enables taking vital parameters, saturation, pulse, PA, and we have incorporated a tablet that is in the same briefcase. It's got a 4G chip, and the doctor, when they go for their rural rounds, they can access the ambulatory clinical health records. They can access their schedule. They can do a teleconsultation with a specialist because they may have a diagnosis question, and they are in a center is 400 kilometers from the capital. And so we have deployed this in the whole territory, and everybody wants to have the telemedicine briefcase. And now we have started working with specialties offering from Montevideo. In Montevideo, the home of the reference centers of ACE, the Pereira Rosell, which is a reference center for pediatrics and for gynecological and obstetrical aspects, and these are the specialties that are being worked on. There has been one that has been a pilot, and to have an idea of the repercussion that this has had, the families have stopped traveling for having a pediatric psychiatrist consultation. They would have to travel from Artigas for about 600 kilometers to Montevideo, and they arrive without the corresponding studies for the specialist to do the consultation at the time. And this has given very good results. We have nephrology, gynecology, high-risk obstetrics. The Hospital Español is an adult hospital that offers cardiology, diabetology. There's a pre-operational circuit, and we did a pilot test there where the anesthetician and did the pre-operational evaluation of the patient before, and this has given very good results. And now we have incorporated a month ago adult psychiatry, which every week changes the points of distribution of these offerings in the different points of the country. 1 week we will do Rio Negro, and another we'll do the province of Artigas or the province of 33. And that is how we change with the different telemedicine nodes that we have in the territory. The INOT, the Traumatology Institute, and the Maciel Hospital, another important adult hospital with these specific specialties that you see there. Rheumatology, the Saint-Bois Hospital. We have done a special work with allergies. It's a modality that we call asynchronous, and you probably have heard about it. What we do is that the first level doctor can do through the ambulatory health records. They can do a consultation for advice with the specialist that is located in the higher level, and the specialists, when they have time, they do their consultation and they can see the images, and they do the advice for the consultation for the first level. And we have allergic access from all the points of the country. I don't wish to bore you with all the specialties of the Hospital Pasteur and the Español, the Pasteur, and the Maciel hospitals have special halls of telemedicine, and these spaces are devoted especially for the specialists to do teleconsultations. There are their own schedules that we do especially to provide the service for all the country and prevent our users from having to work a lot of kilometers and have expenses.
These are the notes for the first and primary telemedicine. Artigas, Rivera, well, all the names of our provinces are there. Our demand was studied. We could see where the demand was the highest and where we had the conditions to develop this. Obviously, the telemedicine development requires certain connectivity. We did that with our IT department in the territory that was assessed, and these are the points in the territory. The main modality is the synchronic doctor and the specialist in a synchronic manner. The doctor presents the patient to the specialists. Then there is an ambulatory medicine. Both professionals record what they do. Then asynchronic, provider to provider. We can see that this is very well used. During the time the doctor is idle because there were patients that did not turn up, then the doctor can answer these appointments. And then direct teleconsultation, doctor-patient, because we have to look into certain conditions, confidentiality, so that a user is not making a teleconsultation from a bus. I mean, there are certain conditions that must be met. So we are developing an application with the IT division, the user portal, whereby the patient will be able to have all this technology in their cell phones. We're going to be testing this with the specific populations. Communication is fundamental. Thanks to PAHO, we printed banners and that we post in each one of the centers so that users can ask, what's this about? What's telemedicine? Well, we have videos that we show in waiting rooms while patients are waiting so that they can know what the project is like. And we also hand in brochures. The work with the IT, with architecture, where we design telemedicine rooms so that in the places where new constructions or reforms are made for telemedicine rooms, certain conditions must be met. We have specialist offices which are mobile, designed for specific places where we have to change place, and then we have offices with patients, and there you have all the requirements, light, the angle of patient, where the patient must be located, the audio, and all those characteristics that must be taken into account to develop these projects. All that is included in this document, and PAHO helped us a lot. It's the implementation guidebook of telemedicine in ASE. All ASE services will have access to this. So if you want to get involved with telemedicine, what the requirements are, what's the checklist. If I don't comply with this, I have to go into the IT department, processes, protocols, architecture, how the agenda is organized, what are the modalities. Everything is going to be in one single document where all services, all centers will have access to. And we think this is very important to develop telemedicine better. This is just to show you some photographs of the pilot sessions. There are some conclusions that I'd like to share with you before I conclude. It is important to work in the territory telemedicine services can't be implemented from an office in headquarters in Montevideo. You have to go out to the territory. You have to see the peculiarities of each center, because there are cultural issues, organization matters. So it's fundamental so that the tool can be adopted afterwards. According to our experience, we've seen that, all right, you start with telemedicine, we give you the equipment, and they don't start, or they start for a week and then they stop. That's why it's fundamental to work with them, and after the implementation, to accompany them. If you are accompanying the services, there are always questions coming up. We produce a telemedicine community through WhatsApp where we have the various nodes, and they can exchange issues. If there is a problem with connectivity or if there are other questions, they can always find answers for those who have the questions for the first time. As I said, this is a cultural and organizational change. It takes time, but we always have to move forward. You have to be patient. This is an opportunity to redesign care processes. It's important to work with GPs in each specialty as well, and for the most frequent approaches. And lastly, I would like to highlight how important PAHO cooperation was, as well as IADB. We were sitting around a table thinking about how we solve these problems. They would travel and come with us to the various places to solve the problems in the community. I would like to highlight that because that's most important. And to conclude, simply I would like to say that technology per se is not going to solve health problems. Technology per se can make it even more complex sometimes. But if we have technology applied to clear and defined processes with professionals and specialists that have been well identified, it can be highly beneficial. We all know the benefits of telemedicine for our users. I think that's the road to take. Thank you. Thank you, Marcelo. This is a very comprehensive program, an extraordinary example of a telemedicine program here in Uruguay. I think that we have complied with the goals of this workshop to share initiatives, experiences, and how you can favor APS and non-communicable diseases. Now we have time for sharing ideas and talking. So please, I would like to ask all the presenters to come up front. If you have any questions or comments, anything that you'd like to say about telemedicine in Uruguay or the PHC in Jamaica or mental health or the initiative of APS or anything, PHC, anything, please let us know. This is the time. Over there, please. Good afternoon. Congratulations to each one of the presenters. I'd like you to explain how you were able. We know that a file is a legal medical document. How did you go from a written document when there is an interactive consultation to a fully electronic record in a telemedicine appointment? That's a good question. Perhaps, Marcelo, you can answer it first. Well, in fact, we had already developed the ambulatory clinical record. We had done that, and what we did was to adopt it and adapt it to telemedicine. The system had already been built. We had a long experience of use. It was used very well in all our services. The only thing that we did was to make a specific development with IT departments so that we could clarify that that service that is being provided is a telemedicine service and is not a face-to-face appointment. Then the skeleton, let's say, of the appointment is exactly the same as the one we use for the face-to-face appointment, but we have to make that development to tell the difference between a telemedicine appointment in order to have data later on for management, and because it's important to know that this wasn't a face-to-face appointment, but an appointment between two professionals, for instance. To supplement what Marcelo said, well, I fully agree with what he said. The important thing is to respect the documentary process. If you have paper documents, even if the communication with patients is electronic, you have to continue having the legal document, which is in paper. For instance, if your country has an electronic medical record and you use the PAHO video consultation, you can do it like that. But the document must be recorded in the document. And that's perhaps your question, right? This is the concept that we all wanted to convey. Apart from the tools we use, we have to try and not to have islands of patients, but to document what the legal documentation in force is in each country. Mario Sanchez from the Inter-American Development Bank. I would like to congratulate Marcelo and Uruguay on this program. Are you thinking about whether there should be an impact of telemedicine in clinical practice guidelines? I'm thinking about mental health care. There may be some patients that must be synchronic with the patient present to see the way the body moves, how specific it should be. Telemedicine is changing or makes us look at some clinical guidelines. And the other question is whether you are thinking about making an assessment of that intervention in comparison with face-to-face intervention, because there's lots of evidence at international level that that type of intervention works out well, that can even improve the patient's health, but devil is in the details, and it would be good to have a good assessment. It shouldn't be option B in this case. And I would like to know your opinion. It's a pleasure, Mario, to get to see you back again. Your question is very good. Protocols are fundamental. Protocols to approach telemedicine are fundamental. That's why I said that to work with the clinicians is most important. It's not a minor issue, and it's difficult. It's difficult to agree on this. We're trying to make university services participate, all the chairs, because in that way the specific protocols that we have by specialty, an important backup to approach telemedicine. These documents, not all patients qualify for telemedicine. There must be inclusion criteria, exclusion criteria, more frequent pathologies. What is it that I should have to approach a certain pathology? All that must be described, because otherwise the patient would get to the appointment. It's going to be neither effective nor efficient. There are going to be tests that will be missing, or simply because that wasn't the case to do it, to have an approach through telemedicine. And I can't remember your second question. Yes, about assessment. Well, Rosario Berterreche, who you probably know well, we worked together with her very strongly in a chart You have to measure the impact. It's fundamental. Very subjectively, I can tell you that this works out. We are seeing it in practice. There is a higher demand of our services in this way, and it supplements perfectly all right with the face-to-face appointments. And this is what we were working on when we were dealing with change management. The specialist will give you a more effective and efficient appointment.
Impact of telemedicine services and making sure it's not displacing the personal. And I'm curious from Jamaica's experience as well, because I know you've invested a lot in telehealth in Jamaica. Has there been any evaluation, or are you planning to do any evaluation?
Well, we have just started, and again, with the Health System Strengthening Project, it is really very widely encompassing. We've just introduced electronic health records. We had our first rollout, first hospital last month, and so that is going well. We have not. We have done a bit of telemedicine in terms of the tele-echo that we use for continuing medical education, as well as for some teleconsultations with specialists. We have not had an evaluation of the program, but I must say that tele-echo has been around for some time. We've used it for HIV and for sickle cell for many, many years. I cannot say that I have seen a formal evaluation, but it's certainly something that we're building in, a monitoring evaluation framework for all the interventions that we're putting in.
Wonderful, wonderful. Thank you, thank you. We have another question? Oh, sorry.
Muy buenas tardes.
Good afternoon. I'm really excited about the presentation. My name is Mario Rovere, and I would like to make a question that has to do with the panel that's coming later. It's a bit taxonomic to have telehealth on the one side and teleeducation on the other side. I wanted to ask mainly about the aspect of training aspect of consultations through this means, because I think that the evaluation logic, we should also see the aspect that there is a time of interconsultation, that the objective is for them to disappear so that the first level of care develops a resolution capacity, and telehealth can be used as a teleeducation tool. And the other aspect that I thought was equally interesting was the aspect of indicators related, at least in Argentina, where there is a pediatrics network that is a bit ahead concerning others. The indicators concerning the times, the reduction of transfer times of patients as an evaluation item. I don't know if you have a answer, Charlie. The idea is to be within the plan, and most of us as health professionals have been trained based on that. And this model of care is also an educational process, and this has to do with the instances that support the telehealth process, which, as we saw in Uruguay or in Jamaica, everything surrounding the consultation will also favor the teleconsultation, or the derivation with the professional is not only related to knowledge, but also to the possibility of executing further steps. And so advancing those steps in teleconsultation is also necessary. There's a balance of the teleconsultation models that we see today, that some cases have to do with the lack of experience and specific topics, but also the limitation of the teams on the ground that do not have the tool or the authorization to continue with another stage And we see it even in mental health that some prescriptive aspects are not in the first level of care, and it's not a lack of knowledge. So it's not only a technological problem, it's a much broader issue, and this has to do with education, obviously, but we increasingly learn and we use it as an educational strategy. But there's another big aspect that has to do with regulatory changes that will be necessary. There are 3 questions. 4. Thank you very much. Jacqueline Ponzo from the Regional Organization of Family Medicine and Community Medicine. And I wanted to ask about the role for this specialty in the telemedicine project in Uruguay, specifically ACE. It's the main aspect of relevance for health professionals, and this interventions really encouragement, because as Marcelo was saying, the interconsultation with specialists, I'm asking then, interconsultation with specialties is included with family and community medicine specialists, and at the same time to also bring forward the aspect of the care model, that telemedicine is a tool that will lead to transformations in care processes, and these are welcome because they are necessary to increase accessibility, but we should still consider the integrality of the care, which is one of the substantial contributions of this specialty that sees the person as a whole. And many times the specialist in family and community medicine requires telemedicine to interact with other specialties to improve the accessibility of patients and prevent those wastes of times that are perversely included in the system. So I really wanted to raise awareness with this question. We'll take 2 more questions and answer them together. This is Gabriel Paredes from the Department of Santa Barbara in Honduras, and I will pose it as a idea more than a question. The telemedicine project, that is something that has been implemented after the pandemic in most countries. There is a need of a solution to a demand that was already natural. We know as doctors that patients always are making questions by phone, but we are making it more professional, more formal. I was surprised in the previous intervention concerning the in-person appearance of patients, and you know that you cannot separate telemedicine from in-person care. And with the project that we were presenting as Honduras for strengthening the first level of care with a primary care with family medicine, it would be interesting for those protocols through telemedicine to incorporate a visit to the site or to the family, because the characteristic of the demand of telemedicine is a lack of access to healthcare services. Maybe in the city they do it, in urban centers they can do it so that they don't waste time. But in countries such as ours, where the rural areas are very mountainous and difficult access, people do it in this case, where it has been incorporated as a pilot in some points, because they don't have access. And maybe they will continue without access. So these community multidisciplinary teams in the different countries will have to include in the protocol the later visit to the teleconsultation to complement what was seeing and verify what they see in the physical examination. So telemedicine has to be incorporated not only in the interaction with between the second and first level, but also with community work. Thank you for your comment, and now we will take another question because we are running out of time. Good afternoon. Marvel Madaña, Director of First Level of Care of El Salvador. It is a question to do telemedicine. We need a number of staff, healthcare staff, and there are facilities where we have 1, 2 doctors and the ones that are farther away. And how could we prevent overloading, or how have you thought about the times that the doctors will be needing? Because if you travel or you have your office and you are taking consultations, but many times the consultation will continue while we educate the population. And the other thing, there is a sort of monitoring is there a sort of monitoring to see the quality of the care that is being given? That is, the telecenters, when it's a telephone call, you can listen in. But how will we be monitoring that the care is good? Very good questions, and I think we can answer. I can respond in general, so we go to the specific Uruguay question about Uruguay. Based on the 3 questions, telehealth is not mandatory. And Marcelo said it clearly, it's a balance between protocol and criterion. The professional who is in charge of a patient, if they think they will not benefit from telehealth, they don't need to offer it. That's what it means when we say that it's not mandatory. And in this sense, it's logical to have questions about whether the quality of service is the same or not, but we shouldn't consider it different from an in-person consultation. If I don't observe, I don't measure, I don't record the in-person consultation, why does it tempt me? I understand that it's easy to record a teleconsultation. Why would I do a teleconsultation? To make sure that the service is ideal. But if I have a situation where my system can measure the quality in the in-person care, and I want to replicate it in telemedicine, but that's okay. But we shouldn't request different things from a new model of care, because sometimes we make it more complex. And I know that some countries request specific consent for teleconsultation, but the patient themselves is accepting it when they request a teleconsultation. So there are no specific consent would be needed. But I understand that as something new, well, not so new, but in the process of implementation of a new model of care, it can generate some kind of alert, but we should take it easy and go slowly, work with the teams, as everybody mentioned. And as it was mentioned this morning, work with the teams. And to me, the word is the balance between protocol and criterion, and to know what we have to do, to know what happens when it doesn't work, and see whether in the protocol, the medical or nurses criterion says that whether that patient would benefit or not with the model. And that's a bit of the idea that we communicate concerning implementation methods. Now, about the other question, telehealth doesn't do magic. If there is a lack of resources or a lack of hours available for care, it will not be solved by telehealth. As we were saying this morning, the demand exists. It's not that the demand appears with telehealth. It was invisible. But this is where we talk that these are not technological processes. They are organizational processes that will require an observation of how this program is assembled. And it has to be accompanied by exchange. For Jacqueline, for us, the role of the family doctor is fundamental in this aspect was an offerer and as a requester accompanying the patient requesting a consultation with a certain specialty. We know that there are some specialties that are unfortunately concentrated in Montevideo, the metropolitan area. We can offer that family doctor who is in a more remote area they can have access to a consultation with the specialties and have the tool to help their patient. And this is not a minor element that telemedicine projects per a decision of the ASE authorities are in the first level of care. They're not in the second or third level because the objective of the institution is to strengthen the first level and increase the resolution at the first level. And the family doctors are essential here.
A very short comment triggered by your question. Once you have set up the infrastructure for telehealth, it's us who have to become creative. And modalities may be infinite, patient with patient, health agent with a nurse, the question of who connects who and who we visit and who we don't. That's where we have to become creative and see how to get to everyone. Well, thank you. I think that we have completed this workshop. I would like to thank all the presenters and you for your time. Thank you.
Un par de breves, muchas gracias Silvana y a todo el panel nuevamente. Un par de breves avisos. Haremos un receso ahora de 15 minutos y hasta las 16 y allí vamos a retomar con el trabajo de 2 talleres en paralelo.
We're going to have 2 workshops. Room A is workshop 4. And then in room B, on the second floor, we're going to have workshop 5 about comprehensive or integrated networks. So 15 minutes break and we come back in these 2 rooms. Thank you.
Arriba en el segundo piso.
Hola, buenas tardes. Vamos a empezar porque estoy segura que a las 10.
I'm sure that at 5:30 dots we'll have somebody running after us. I'm Isabel Dure. I'm consultant and I've been working for the virtual campus and the Human Resources Unit, and I'll be the moderator of this panel. I wanted to thank the organizers for giving us this time in the event, and also you. We're reaching the end of these 3 work days, so thank you so much for coming. I will make a brief introduction because we're going to speak about capacity development in PHC for person-centered models of care, and some considerations. Training are processes that occur in individuals where we have capabilities and prior experiences. We train ourselves, we all do that, and we do so via different mediations throughout our lifetime. Mediations, the academia, mentors, our readings, currently the social networks, but essentially work contexts. And now I ought to add telework contexts. Each worker will build their own trajectory. That's why we'll refer to them exerting their right to train throughout their life. Individuals are autonomous for our training and also in our work process management. So, how to make compatible individual and collective rights, how to gear training and educational processes of our workers to strengthen PHC and to have better access to the health of our communities. We're here because we acknowledge that PHC is a pathway towards resilient systems. And because we speak of paths and not trajectories, our director asked us to work on a training trajectory in PHC. This is a path through a program of training in different spaces. This workshop will do that. It's a workshop. We want it to be participatory. We'll have a series of presentations, but in turn, we want to hear you. Just to show a training trajectory, we discussed in the technical areas a possible approach for PHC. We discussed, of course, what we are speaking of when we speak of PHC, because you have to consider the approach. And we had an interprogrammatic workshop. We started a joint process with online exchange with the different units, primary care and others. It's an ongoing process, and that's why we want to expose and validate this in different ambits with different players. So, I thank you all for coming, and also our boss, James, who's supporting us in this initiative, and to consider capacity building. I will introduce our panelists who are invited to come up. The head of Human Resources, Benjamin Puertas. This morning he chaired a very active football panel also, because to speak of teams, we refer to football teams also. Gabriel Litowski, head of the virtual campus program. This isn't only a platform, but rather an area responsible for developing technical and pedagogical guidelines for educational proposals in public health. 2 people that manage capacity development at subnational level, Cecibel Respolo, coordinator of the regional teaching unit of the Ministry of Health in Panama. Thank you, Cecibel. And Mario Roberes. He's provincial director of the Health Government School of the Ministry of Health of the province of Buenos Aires. He's a centrist and an inspiring teacher and always makes questions. So it's a responsibility to chair this wonderful panel, and I'll invite Benjamin to start with his presentation. He'll give us a conceptual framework for our organization to speak of human resources and particularly training. Good afternoon, everybody. It's a pleasure to be with these colleagues in the panel. That is ultimately a workshop. As a human resources unit for health, we want to speak of the strategy for capacity development in human resources in the context of PHC. Well, we don't have to emphasize what we know, what the pandemic involved to exacerbate this lack of human resources and poor distribution of health human resources in the territories, but particularly insufficient investment in training and professional development. Challenges regarding human resources are multiple, varied and complex. If we only look at the titles, we'll have challenges for governance and leadership, access and quality, and specific IT systems for human resources and health. I was discussing with a colleague from Uruguay in the private sector, and we said, how can we obtain information from the private sector? We have challenges in the public, imagine in the private, and in education and training. And among the specific challenges for educating human resources for health, we have something we've discussed, and that's a lack of calibration among the education and health sectors, more particularly when we speak of competence-based teaching, the lack of integration of training strategies. The pandemic also taught us to appreciate the online methodology. We were used to face-to-face meetings, but now we have a hybrid option that has interesting results. It's worth knowing. There is an inconsistent accreditation of training programs, and that's also a major challenge. Absence of continuous education plans, regulation, and education regulation is a serious challenge in many countries, and the quality of education. Lack of capacity in the teaching staff and students themselves for online training. And here we have experience from many countries where they were reticent to establish online programs to train, and after the pandemic, of course, changed.
In this sense, it's very important for the teaching staff to train virtually with simulation labs, and practicums. This morning we spoke about interprofessional training, and it is limited. The experiences which we have identified in our region, there are some very good experiences, but they're not enough. And when we talk about interprofessional training and education, it's not based on content, it's based on competences. And so in teamworks that are not correctly trained and with the adequate capacities, we have inadequately trained training staff. And the low access to good digital platforms such as the virtual campus, which we will hear more about that. This is especially true in remote areas and rural areas. So primary healthcare, this is what we're speaking on this forum. And the strategy for extending and expanding primary healthcare. We need to begin to treat barriers to access. We need to continue giving services in the community level. And for us specifically, we need to increase capacities for health workers in primary healthcare. So what sort of personnel do we need in primary healthcare? We began to speak of this morning of interprofessional teams. And you see all these different categories of personnel for health workers you can have, and community agents and social workers, midwives. But basically we need staff in primary healthcare that is going to give services related to prevention, promotion, treatment, rehabilitation and palliative care. We want a workforce in public health. we need them to be committed with social determinant and environment determinants. And we cannot forget volunteer carers and lay carers. And we spoke about parents. Our parents are getting old, and they sometimes are taken care of by people who perhaps haven't had training. They're just carers who are voluntary or not, and they're taking care of our own family members. And we become family member carers at some point as well. That's important. How do they complement that work with professional healthcare workers? So, considering this, what are the competencies and the abilities the training the personnel should have in primary healthcare? They should be aligned with these new models of care that we're trying to do. The WHO proposes a series of competencies that 6 domains and 24 competencies that is for the workforce in PHC. So that should be interrelated and focused on people, on the person, on decision making, on communication, collaboration, evidence, practice based on evidence and personal behavior. So now I would like you to think back in time and tell me how many of you learnt about this in your academic institution. I don't mean medical school and nursing school. In courses that you've done somewhere. And imagine again when you were a student in university. If you considered these domains and these competencies here, how much interest did they generate in a population that was perhaps not abilities and clinical abilities, surgical abilities, and I can put myself in that position. When I considered studying public health, I thought it was a bit boring. And when I saw those issues the first time, I was looking for something interesting, epidemiology, closer to the hospital, the better. But I found these competencies that were completely different from the clinical training that I'd received to that point. So here's where we need to consider this practicum, the space of the community where we're going to generate that bridge that is allowing us to understand the need for specific abilities and competencies that are focused on people, and not just on an individual level but also a community level, and have a holistic centered care. And so these decisions that are going to be made by an interdisciplinary team, and it's going to be collaborative when we need to have a system-based focus, not a hospital-based focus. And we're going to aim at problem and conflict resolution, and how creating a workforce that can adapt to the dynamics and unexpected changes such as a pandemic like we had. That is the way we need to build that bridge, and the personnel and the health workers begin to communicate and learn how to communicate and collaborate with nurses and community agents. They need to learn from others, expand their roles at work, base their clinical practice in evidence, and their behavior, professional behavior and personal behavior is going to be collaborative with other colleagues as well. That is the way of generating that link, because if not, we will have the same workforce that thinks just of clinical abilities. So, drawing to an end, we want to transform the education of human resources in healthcare. And there are several ways of thinking of this transformation. For example, WHO speaks about the importance of developing. They're going to begin to speak and practice collaboratively. A direct admission of those who of graduates. The criteria for admission should direct our students to where we want our professionals to go. And if we want to retain them, there need to be criteria that adjust to that, like that they should be in the area. For example, that increases retention there. Simplifying specific education itinerary into professional education, accreditation and certification. and a continuous development for healthcare professionals. On the other hand, there is other evidence that talks about accesses for the transformation of education. Here are 3 which we think are essential, and based on those ones we see from the WHO. One is education based on competences, and so this is repeats education and capacity building interprofessionally, and applying technology, information technology, to education. This is a tool that we need to bear in mind. The policy on healthcare professionals approved by PAHO for 2030 has 5 specific lines. 2 of them bring us closer to supporting countries in this area. One is involved with strengthening interprofessional teams, and another is more related with today, which is increasing the development and strengthening the capacities of our personnel. And so there needs to be a close collaboration between the different sectors of education and health, virtual training, simulation, and training camps in the field, updating capacities based on empirical data, and strengthening continuous education and this virtual campus. So what is the direction we are going in? Those specific axes that we need to strengthen, and the PAHO proposes some technical cooperation lines for supporting this plan, such as supporting and developing the implementation of policies, and advocate for the integration of these sectors. It's not just education, also finances. We've had the banks and other having a dialogue on this, which is more fluid when they are here with us. We need to establish recommendations for a framework of competencies. It needs to be adapted to the country, to the context. Want to contribute and promote plans for continuous education for the personnel. We want to identify specific professional profiles and support the use of digital platforms. You also want to support the implementation of methodologies which are innovative in education. So, for example, World Cafe. This is a new methodology that has different elements, and those are innovative methods that we need to consider and analyze them and bring them to Latin American context. Should support the systemization of experiences, publication, and scientific development. And this, of course, is hard for us Latin Americans. We need to monitor and evaluate and certify. So this is Nelson Mandela's phrase, which I think is very powerful. Education is the most powerful tool that can be used to change the world. And this was someone who was 20 years incarcerated. Thank you very much. Thank you, Benjamin. Benjamin began to bring us the itinerary to think about what we need, the framework, epistemologic framework, and the profile. And so this is the session we had this morning. It also allows us to give specific subjects to primary healthcare. We talk about our teams, we talk about human resources, but we find it hard to make those links because often it's difficult to work on. Now I'm going to invite Gabriel to talk about the concept of formative itinerary and lifelong learning. Thank you. Good afternoon, everyone. It's a pleasure being here with you. It's been a pleasure for me to be with you in these 3 days, listening to the different presentations. Thank you also, Benjamin, for introducing the panorama and the complexity of human resources. I would like to start by saying that in these past 3 days, the virtual campus has been present when we talked about non-communicable diseases, the elimination of specific diseases, when we talked about mental health, when we talked about telehealth. And in each project that's been spoken of in these days, and the virtual campus has been present. And that gives us great satisfaction because it shows us that the campus is contributing to capacity building and competencies of work, healthcare workers, and we are working with healthcare teams and the systems and focusing on primary healthcare. However, I'd like this presentation to be perhaps more related to problems and challenges which we want to work on together. I think we have a lot of challenges ahead of us. The virtual campus is a public property. It thinks about permanent education in the work. It has open and interoperable resources in the same ways that other platforms in the Department of the Department for Action was presented in these days. There's a collaborative management and it hopes to be sustainable. Many of its processes visit the different countries with different versions, updates. I'm very pleased, for example, to be in Uruguay where the products of the virtual campus related to mental health work interoperably in specific virtual programs for Uruguay's Ministry of Health, and that contributes to our responsibility of generating good products for education in the virtual campus. This is the panorama of our current virtual campus. Here you see that there's a colleague who they're a user of telehealth in different parts of the world. We have more than 2.5 million users, which is over 6 million inscriptions. Each person who uses us for one course, they probably interact with other products on the campus. There is a strong growth in technical workers and students who also begin to slowly use the materials provided on the campus because their university classes recommend them. And they're invited to get familiar with these campus content.
That is why we think that the campus is also an opportunity for that articulation. We have close to 100 courses always open in 2023. We opened already 42 courses of self-learning at regional level. We accompanied 10 courses with tutorship and cohort and accompanied what we call country hubs, over 40 classrooms for projects focused on country needs in an articulate work between the National Health Authority and the PAHO office in the country. Some central matters when we refer to the issues I want to share with you. This is the educational approach for public health virtual campus for the organization. It's available there and it poses the challenges we currently have. Dr. Dure presented it when she opened personal training needs and certain needs of the health services. What do I want to study? How do I want to train? And what do the health services require? How to articulate these needs to respond to training throughout the health worker's lifetime. I need to train 40, 50 years as each of us, and how this training is recognized, appreciated, certified by national authorities, governments, and universities, but always thinking that this training aims at accompanying the health service transformation. And now I will focus on problems, training trajectory in health. One of the challenges we have for 2024, one of the central periods for Barbosa in the coming years. In the virtual campus in 2022, when we reviewed, he corrects himself, 2023 of all products, we found that all courses include PHC. They all refer to PHC. However, we have conceptual approaches that vary. We approach PHC from some areas: mental health, alcohol abuse, the use of medication. We speak of practice considered for first level of care, but we forget the PHC strategy at all levels in the system. We have heterogeneous proposals, some that are long lasting, some with little time devoted to them. And we haven't found a manner of articulating all these proposals. This is a challenge of the training trajectory and an invitation to work articulating with countries and regions in this regard. What is the contribution of the training trajectory? What do we want to build? What are we working with? As Benjamin said, we must define priority competencies according to professional roles. Each country may later define the sort of work where they will use it, but we must think about competencies according to roles and visualize our courses in this line. Hierarchize training, reducing scatter and lack of continuity of proposals. Guide, direct, because the training trajectory is an epistemological unit at international quality level. This is something we're really caring for actively, quality criteria in each of the campus products during the monitoring of the UNESCO, WTO, and other guidelines, and now working hand in hand with the WHO Academy. And a central matter when we speak of individual training and transformation of services, we must consider certification and recognition the worker has throughout their life training. How many of us have in our portfolios 20, 30, 40 certificates from different scattered courses? How many of us have certificates from different work experiences in practice, but they don't create a continuum, even if we're certified and accredited? This is an essential challenge from the standpoint of the lifelong learning and the international standpoint of the recognition of micro-credentials to health workers. And in this line, what is educational trajectory? A pathway that must acknowledge courses, workshops, seminars, webinars. We are placing our stakes and working with an educational itinerary that is a spectrum of options for countries and universities, and parting from it, create a package of contents that each country and institution requires. There may be a mandatory and optional parts, and it's a strong invitation to work in collaboration with countries. Why do the same thing, repeating the same product, if we can circulate and socialize and share it? How can we add efforts in a certification granted by one government or by the virtual campus, or with academic accreditation from universities in our region? We have many using campus certificates, accrediting at academic level with optional and mandatory courses for different levels. Now I'm going to share some slides briefly. We're working in a training itinerary in the Medication Regulatory Agency to integrate products of the virtual campus, and this is an opportunity it provides to articulate political and institutional decisions, pedagogical ones, the cultural perspective, to gear products to different subregions in the organization, to consider the epistemological perspective so it's scalable and affordable and built as we use them. And here I would like to give these two examples. This idea with the tree that we're beginning to use thanks to colleagues from medication and technology shows that we have a system and it has essential functions that we ought to know. I invite you to think about the educational itinerary in PHC. What are the core competencies we all need? Which are the courses we need to do once and make the most of them? What are the competencies that some professional groups later need? And how can we go through this path with materials, some mandatory and necessary for certain roles, others optional, others for another specific path, for those doing management or decision making. And here the same tree in a more schematic representation in detail, showing the different thematic models we could build and how these thematic models may be organized according to the need for each professional group and role, and how to build the training itinerary that each project or country needs. And to end, it's okay with time. So, as Dr. Dure said, this is the first activity we host outside the organization, and we're inviting you to this challenge to work in collaboration together. In October, we had a first interprogrammatic meeting with the colleagues in the organization where we found these comments, the scatter, diversity of perspectives, realizing that we're repeating same things without knowing each other and that we must join an articulate effort. Some agreements are there. The itinerary offers an appropriate response to multiple demands for courses and certification. The PHC itinerary should be geared to the first level team with a perspective of interprofessional work. This is related to today's morning activities, strengthening this view of interprofessional teams, and should also take into account as a PAHO responsibility managerial roles and political decision-making levels, and ought to be designed in articulation with an assortment of experts. And in that sense, we have already established, as Dr. Dure said, at the Health Systems and Services Department, we have a first team working on a roadmap and to elaborate a first course with a conceptual basis that we share that may be used in synergy by all. This also goes hand in hand, and I go back to close to some developments and challenges in the campus that has been working for some years, and now we have this practically ready. For example, to hand a virtual or online certificate that we may print and keep in our portfolios, but also a budget so you have it in your LinkedIn or have your virtual backpack adding your micro credentials so you can tell if you are postgraduate students, I did these courses in the campus. Do you recognize them as credits? I work in the first level of care in such and such a country. Which are the courses you recommend? Because this will be recognized in the framework of my work incentives. And last, something that doesn't have a name yet, but is related with this possibility of having an analytical document in the virtual campus with the training history that each of the users made. And this with an invitation for you to work in articulation and in an interoperative way with the diverse platforms in the countries. We believe this tool should circulate and articulate, making a human resources program in a country recognize campus certificates and add their own platforms and have this possibility of offering the health worker a history of the whole training. And I want to thank you for allowing me to share these challenges. Starting today, we want to enhance collaborative work on the project, promote interinstitutional articulation, and work hard to recognize different manners of certification and micro-credentials in the region. We are responsible and share this responsibility. During these 3 days, everybody said that behind each of our products we have people working, people making major efforts, and we must really pay attention to how we acknowledge the development of their capacities so they continue working every day better. Thank you. So, if you didn't enter the campus yet, you're invited to do so. Thank you. Thank you, Gabriel. Training itinerary with diversity articulation. I think we are including subjects. The virtual campus is a great innovation. It's 20 years old and it improves every year, offering a diversity of possibilities and progressing increasingly to build networks. Sassy Bell, you can now tell us about the Panama experience in this training itinerary. I have to adapt it. The pros of the virtual campus in public health is that it offers people who are in the learning and process to take all the courses they can at their own pace and style. Good afternoon. I'm Cecibel Ruiz. I am a dentist, but I've been working at local level over 30 years. And 3 months before the pandemic, I practiced in a difficult period the coordination in a province called Veraguas. And there's a story to see water, Veraguas. So, on that occasion, well, I will share the challenge in capacity building in primary health care.
Our vision from the local perspective, this is a project that has been done collaboratively, not just myself, but we've done it with, I want to highlight the work that we have done with other units because we share many things in our country. This is the building, the administrative building of the Ministry of Health of Veraguas. A few years ago, it had the only regional hospital that we have, a second level, the Fábrica, and it was built there. We don't take all of that, it's quite large. In this talk, I would like to share a few general aspects about the province where I live and work. And then I would like to share the challenges in our environment and the development of capacity building from two perspectives. One perspective is considering the environment and the other one regarding individuals. And then I would like to share something about strategies to impulse the development of capacities and this formative itinerary. Our country has experienced economic growth in the last few decades due to its geographic location and the success of the Panama Canal. We have an important service sector which is very dynamic, finance and commerce. These are some data that summarizes our small country, which is currently growing, and it has quite a young population. And we have a economic stability and a life expectancy of 78 and a human development index, which is high. We have an important expenditure of 7.6% of total expenditure in healthcare. Here I present to you the province where I am currently working. This is the province of Veraguas, which is in the center of the country. It has the Inter-American Highway, which and in 2023 there are 260,000 inhabitants. Our country is also characterized by having very important poverty areas. There is a great disparities and inequalities, and the experts know this. And in our healthcare region, what you can say is that in primary healthcare we have these professionals that you can see here. We have around 75 general doctors, general physicians, nurses, 106, and around 43 dentists, and the rest are other healthcare professionals that somehow or another support us in everything that we do in primary healthcare. Sorry. Our public policies consider certain strategic alignments over the focus on developing human resources. We have a national policy with a strategy for 2016-2025, and the vision is focused on a healthcare system which is humane and with quality and equity. Policy number 6 mentions that we should strengthen the training and capacity building and competences in human resources in healthcare, in accordance with the changing needs of the system and the model of care. So based on this, and based on what we've heard before, I'm going to share with you some of the challenges that we face or have faced in our region. There are challenges regarding the environment and challenges regarding individual competencies. The challenges that we currently face based on the environment is the organizational structure that currently we have in our teaching structure, and that is seen in the local level as well. So, for example, it means that in our organizational structure, we don't exist in a sense. And this affects our functions. And it's seen in all the different functions that we have. And it limits also our opportunities and the time for organization, follow-up and surveillance of continuous education. This, of course, generates a redundancy in the functions because we are responding to a national teachings plan, and then we have 3 obligatory internships in medicine, in veterinary science, and in dentistry. In medicine internship, the interns have to do, in their second year, they have to do 3 months in primary healthcare. On the other hand, we also have a specific and limited budget. For this reason, our teams find ourselves in certain situations where we have to do self-management, request donations to try and fulfill the responsibilities which we have. This also implies or is a challenge is the strategic planning and also monitoring of the fulfillment of our goals. And this is in part due to the limitations that we have regarding training and management. I also want to highlight the aspect of the infrastructure. Our hospitals and centres, our centres, we have 88 installations or centres. There are 2 which are primary healthcare, and only 2 of them have an adequate building for doing this capacity building trainings. The rest, we often do these activities and actions and teaching actions in the waiting rooms, and then a patient may arrive and we're doing a training program, and so it can sometimes be uncomfortable because the personnel has to a sense go and attend the patient and then return to the training session. Now we're going to focus on the part which is related to the persons and the people, individuals. The things related to cognitive challenges, for example, we see, I'm going to give examples. I don't want to, it's related to the specialized personnel and staff. So, for example, in specific competencies for promotion and of health, because we have specific places for doing this resource. However, we know that all personnel should be trained in promoting and educating in health, in their discipline and the health. But due to this multiplicity of functions, they aren't able to do this. And we also need to reinforce the strategies for effective communication in a changing world in which community is more informed, and so they expect and demand more from the personnel and from staff. And it's important for staff to know how to use informatics and the technologies, IT. I may know about it, but I haven't developed how to use it timely manner and adequately.
Okay. ¿Se fue? No, ese es el saber hacer. Como ya hemos mencionado,
as we've mentioned, it's not enough to have the knowledge in using the technology available, but you need to be able to use it adequately so that it's a support tool in clinical care. We know that there is continuously development of new apps and platforms and IA, because if we know how to use it correctly, it's an excellent help and aid in teaching and training. Primary health care requires individuals who know how to communicate with empathy and assertively, because technology, we have to work with the individual that we have before us who comes to a healthcare center seeking care, and so we need to work on building communication abilities. And each place there are problems in communications, and we need to bring these issues to those who are decision makers, and those who are working in primary care need to also develop research. And for this, they also there's another challenge, but it's how do we develop a protocol and everything that is related to bioethics and administrative processes to carry it out. and also to understand and share our results through publication, perhaps socialization of our research projects. We want to do things. This is the latest challenge for me because it depends on the individual's desire to change, to be proactive, to learn, perhaps unlearn specific behaviors. In some scenarios, we're witnesses to a crisis of dehumanization of medicine. We've realized that human beings resist to change, and it often comes with when there is a process that to empower patients and the workers. And to close this part, I want to say the ability to do, you need everything that we have mentioned before this. Regarding the strategies for the development to improve capacity in primary healthcare from a local perspective, we have tools such as the virtual campus. And within the virtual campus, we have formative itinerary, which are tools in which we can select a group according to regarding the competences in primary healthcare that I wish to develop. I will show you an example in the next slide. And also in this campus we can find different modules for auto and self-learning, self-paced learning. And you can develop, we have workers when they come to the institution for the first time, they receive an induction training. That can be done through the virtual campus. Issues relating to user care and the internal policies of the institution. Also, we have practice communities, the community of practice, and then the construction of a database or a library of resources for all the facilitators, which can help us to develop new courses which are within the formative itinerary. This is one of the strengths that we have developed. We have alliances with universities and training centers in our province. These are the competencies for primary healthcare that everyone knows. And we have developed a scheme for a formative itinerary, selecting 3 of these competencies, and we have selected a group or identified a group in particular to build the framework of this formative itinerary.
We are developing it. So, the 3 competencies we want to develop in this training itinerary. Well, I'll first speak about the group we selected during the COVID pandemic in the Veraguas province. We appointed close to 30 physicians. Some left to make a specialty. Some are working in the hospital. We have a group of 23 physicians working in primary care. They have been there since then, and they were unemployed or had completed the internship. So what they need is a boost, let's say, of PhD. And for that we selected 3 competencies, and among them we have certain courses in our province regarding the specific features of primary health care with a comprehensive approach, lives, gender, family, community. On the other hand, knowledge management and the use of IT systems, the internet, evidence-based medicine in the management area. As some have already stated, in some universities, they don't really promote this managerial aspect, particularly in primary care. So the idea is to strengthen this related with administrative and managerial functions, leadership, supervision, and coordination, negotiation, conflict resolution. And this was identified to strengthen competencies for PHC and capacity building. These are the physicians, at least some. As I said, they have something like 4 years after graduating during the pandemic. They are just starting to work in PHC, and I think that this itinerary may help them to improve their capabilities in each of their workplaces. Thank you. Quality and affordable PHC as a basis for universal health coverage.
Gracias, Cecibel. Nosotros queríamos traer
Thank you. We wanted to share real experiences, and we have heard very interesting presentations, but now how a real team is composed. And now the demands on the workers in their everyday work based on the programmatic demands. So compliments for your initiative. It's a contribution to our itinerary, how you identify competencies.
Mario nos va a plantear una experiencia desde su experiencia.
He'll tell us about their experience in Buenos Aires province. It's a subnational jurisdiction. Good afternoon, everybody. We're very excited to be able to share some of these experiences, and this relates to the existence of the Health Government School. It was in the province of Buenos Aires, and the main idea, it's called Floreal Ferrara. It has to do with management that started in December 2019. Since then, if you make your arithmetic until March 2020, nothing of what we had decided could be supported, and we had to consider other things because the most important part of the pandemic started. The province of Buenos Aires is indeed very large. It plays a role comparable, perhaps, to that of Sao Paulo in Brazil. It has 17 million inhabitants and a surface area equivalent to that of Uruguay. If it were a country, it would be 6th or 7th in population in Latin America. The Argentine health system is very federalized. That is, provinces play a very important role in health provision. And this province in particular has 85 provincial hospitals of their own. That is, generally outpatient clinics also, but some specialized in mental health, maternity, and children's hospitals. And in spite of this geographic distribution, it isn't so homogeneous because there are large cities that capture great part of the physical and human resources from the region. And furthermore, the province has 200 municipal hospitals and 2,000 health centers. The province in itself has 90,000 workers in these provincial hospitals. So it's a great, huge network with huge complexity. Additionally, how to define a policy related to a PHC strategy when we must agree with 135 municipalities with their own specific roles, and sometimes 135 models. Well, that's what we inherited. in 2019. Somehow, when considering this idea of a government school, this institutionality we didn't have, we had some ideas about the role of the government school, but we wanted to indicate something that is our conviction, and that is, in the field of health, education isn't an end in itself. It's a fundamental strategy for transforming health services and systems to serve the population. And the government idea that we worked on jointly also in Brazil is inspired on two principles. One, Carmichael says this, it's only the conservatives who say management is the same as governing. When there are transformation processes, governing is very different from managing. So government school is a mandate to try to transform the health system in the province of Buenos Aires. And indeed, the changes there have an effect on other provinces. And then Carlos Matos and what he said about the importance of working in the government school. So we had this idea of how to have this school, but instead of doing it from nil, the training directorate of the province had a tertiary institute that is part of the universe. That is the health professional residency systems. It's the largest in the country. We're speaking of 5,500 residents, a polytechnical institute, a nursing institute, and middle schools that somehow were modified with these elements, with this idea of a government school, how this government school could penetrate within this inherited structure. So we had this concept and mandate to intensify public policies to strengthen the right to health throughout the province of Buenos Aires. And we understood from the start that the Alma Ata mandate isn't PHC, but rather health for all. So we called Hannah Muller's quote, primary health care had better luck than health for all. So we think that this is the organizer within which PHC is another strategy, as we learned some time ago. And to organize a government school, it was important to include a research component, but with a translational rationale for research, gathering what is separate at research level, basic and clinical, biological and social, everything that is elaborated separately. And it was important for us to impregnate with a continuous education view, because this provides tools that are instrumental, and this whole critical pedagogy conception that had to penetrate through all these structures, many of which didn't have this view at educational level. So that is then our idea of preparing health government studies, and I refer to Muller again in this rationale of training to lead. So each strategy of what we call diplomas, and we had 12 during this 4-year period, and ought to be related with the intensification of public policies. To indicate briefly, health ministries have programs to try to install things that hospitals do not do spontaneously, because if they did it, we wouldn't need these programs. We don't have surgery or programs, but yes, we do have them related to HIV and TB. That's what hospitals wouldn't do spontaneously. So education had to be at the service of these programs that had to be intensified. And that is what we managed to do somehow, not only parting from the generation of this training pool with an extended sense, postgraduate studies, but including polytechnical nursing and resident training, and called it CINE. That means coordination between different educational levels, because they are in silos with their rationales. Somehow we could say that during this stage, and we're projecting this idea that with this critical pedagogy rationale, let's also work on social communication, popular education, and health. And then we discovered that we offer diplomas to the ministry programs to intensify policies so that they speak with the potential effectors. But that doesn't mean that a program have the competencies to speak with the population, not even the target population to which they are devoted, because we don't have the channels, the codes to reach this target population that is imaginary behind the rationale. And that is a task that is carrying us to create a community radio. For the school, continuous education is related with an educational rationale from, in, and via work, practice services, health services, and preferably in community scenarios. That is why the concept of competencies isn't just the same as the one we have in the world of labor, but these are specific competencies in the context and situation where they will be applied. So delivery is delivery, but home delivery is a different thing. Situationally, we need a different competency for a home delivery as compared to delivery at hospital. And we think that this is also related with something teleological. And what for? Because constant education seems a name in of itself, but it must be connected with quality and warmth of services, access, resolution capability, and coverage. This framework is an ideology framework to strengthen all activities and areas at the school. In this sense, we think it is important to share with you what we've learned chronologically. We would say online possibilities. I don't know if we wanted to do this at first, but a reality forced us. After 4 months, we had this challenge to reach a whole province without being able to move students and teachers. So online facilities were a competency and a main tool. But when we tried many online tools, I would summarize then what the school chose: online education with tutorship.
Online education with tutoring, and that we were able to bring to a greater scale. But we need those two requisite: online education with tutors. It's not distance learning where one may see them sometime. And some of these tools were very strong because they began to connect in the same way that we were saying the experience of the campus, because at this stage we had an interaction with the virtual campus which allowed us to organize some of these things, and that way we were able to set based on the experience that the campus already had. And this development of competency on a greater scale, situational competencies, we could have said to the minister, you didn't employ us for this, but we had to train suddenly 30,000 vaccine technicians who knew how to put vaccines, place vaccines. And that was translated into 43 million vaccines. 43 million vaccines is an enormous number, but it was able to be done with the structure of training up people to give those vaccines. And so we had situations which are very paradoxical that we see in Argentina. So, for example, Argentina gave the order of closing the universities, but the medical students couldn't go to university because the universities were closed, but at the same time they had to come as volunteers and recognize those as clinical experience. So the development of situational competencies was very important, but I'll highlight one thing. We had to teach people how to use personal protection equipment for people who supposedly already knew. But we had to teach them because they knew, but they didn't trust themselves to do it correctly. There was panic amongst the health workers. They didn't want to do it. We had to work with them and do cross control to show that what they didn't know and what they thought they know they didn't, and after supervision be able to dramatically lower infection rate of healthcare workers, which is also related to multi-employment because there was horizontal infections, and that's a problem in itself in Argentina. And then we had the official approval of technical training in promoters and community health. So in our system today, we have organized a increased rate of promoters, which the system and the province already had, and it was an informal system that was organized by the municipalities. But now the educational system of the province of Buenos Aires, recognized by the Ministry of Education, this is the title of a technical degree in promotion of health. We had 1,700 students studying to be promoters of health, and we had 700 students studying for supervision. And also we have to consider the residency programs. As you said before, it's been said in other sessions, residencies was completely oriented to train specialists, and the policies and the normatives said that they had to do a rotation in primary healthcare, and it didn't happen because it said they didn't have the conditions. So we had to invert the order and reverse the order to be able to have a fourth year of the residents who could come to the healthcare centre and primary healthcare. And finally, certain diploma and upper courses which are organized or co-organized with universities, which allow us to once again work on public policies and leadership. And I want to recover the word leadership. It was common in Almada, but we need to talk about it again. Without leadership, it is very difficult to transform processes. I think that I'll just say go through these quickly. So this idea, how can I think we have, even from healthcare, the investment in healthcare in the province of Buenos Aires, and as most of you know, in Argentina there's a dramatic political change, and that political change isn't occurring in the province of Buenos Aires. And I think that one of the arguments for this, where there's a re-election of the governor of the province of Buenos Aires, is because of how the pandemic was managed and the investment in healthcare. When the pandemic ended, we thought that other sectors would come upon us and they would there'll be cutbacks in healthcare, but the province has continued to invest in the development of healthcare. So how do we imagine the future? We want to go deeper in the challenges with international consensus in primary healthcare, a greater development of situational competencies in interculturality, in this dimension of political political, and we want to build research in community service and intensify the cooperation between municipalities and social securities, and a greater linkage between these new initiatives and those that have been revamped. Also, we think that due to the volume, 24,000 students that the government school has, we have thought that perhaps it should become a university institute for healthcare. Thank you very much.
Muchas gracias, Mario.
Thank you, Mario. When I was hearing, one of the things that in thinking about development of capacity building is this ability to develop resilience in the face of the situation. I think that was a very interesting presentation. We have 7 minutes. The director is sat right ahead of me, which makes me slightly nervous. I'd like to know if there are any questions, and then I will hand the mic over to Gabriel to close. Everyone's nervous. One question. One question. You make me more nervous than the director, who also makes me nervous. No, one question for Mario. Mario has the possibility of working in an area where the dialogue with the government is very important. In the meeting this morning, we spoke about all the debate regarding training of human resources needs to be backed by the model of care which is proposed by the government, because if not, the university is doing one effort and they find that the model hasn't changed, and vice versa. So how do you imagine, and you have had the opportunity of being a sub-secretary in Argentina, how do you imagine that dialogue and that need between training and the current model of care? I think many colleagues have a similar experience. What the conditions were ideal for us. We have data that shows us that reformation in medical education has an impact in the choice of residency and specialization choices. We have different new universities in medical education that have that perspective. I think that today we have a nearly utopic idea of trying to bring back the machine from over-specialization and ultra-specialization. There are 7 specialties that have better conditions and better salaries, and I think that we need to try and avoid the market being oversaturated and this paradox of where there's a country where there aren't enough doctors but there are too many in another area. How can we explain that situation? It's because the model of care of the public system and the private system is another, and that attention with the multi-employment that we have is a key factor. Another question? Good afternoon. Try to be quick. Thank you for the 4 presentations. They were excellent. A quick question for Gabriel. I thought it was very interesting, this proposal of a formative itinerary. I think it is applicable in many different scales. And that is the question that perhaps if you can... We saw an example in Panama of a municipality, but what scales could that be work on? Of elaborating these formative itineraries, and could it be with networks, or how could we implement it from a more institutional point of view and governance? Thank you for the question. First, I'd like to say, like I said in the presentation, The formative itineraries is something which has been worked on by different groups on the international level. It's something that is currently being developed around the world. There are different institutions, different governments, different agencies are thinking on this issue and following this line with healthcare providers and services in other areas as well. How do we bring the needs of the workforce and the training processes which we accompany people with? In this sense, the invitation that we have for you is that we don't want the formative itinerary to be a closed box, a unique mandate applicable to everything. The virtual campus wants to have a formative itinerary which has a collaborative dynamic with a diversity of products, and responded to the question thinking that perhaps with the history perspective of the country, that a country can think about, for this country, what is the combination, the package of contents of work that can be developed and be used in this path. Of course, there is an invitation. The example of Panama is one small province, thinking perhaps in local levels and in subnational levels as well. Two minutes to close. 1 minute each. Considering this, within this process of moving on along the capacity building, formative itineraries is one of them. The PAHO has began working on this great challenge in formative itinerary in primary healthcare. It's perhaps a challenge which, as Gabriel said, requires the collaborative participation of many different actors. If we perhaps had began in another area, but the most important and most challenging one is primary healthcare. I would like to also refer to how to bring this down to something real, palpable, and the institutes and training centers see it as such, is talk about networks and academic networks that incorporate different institutions and centers. That is also a way of bringing this down to earth in the institutions that are more related to these processes. So in that sense, the PAHO is working on creating these spaces for discussion through their virtual campus, and we also want to work on training trainers. We are considering a community on an even greater level. These formative itineraries and competencies are directed at educational, interprofessional education, digital transformation, and elements in which the transformation of education in healthcare.
Once again, consortia, as we discussed, academic centers are extremely important, and this is an area we must maintain, and invite the colleagues from the universities and academic centers present to consider creating this network. Thank you. I wanted to conclude that the training itinerary goes beyond an assortment of courses, and it includes the development of a community of practices among the members of this itinerary, and also it includes a careful selection of facilitators, and we may invite some of the panelists present here or from the public who are experts to have a sort of database for facilitators as we could for our region, and that's something we do wish to do. Okay. I wanted to add 2 items. One, teacher training that was mentioned in all the presentations. It's still a challenge in the countries in the region. It's hard to train online teachers. This is a constant demand in the country teams and something we must continue working on in collaboration. And I must thank you for coming and invite you to continue working in collaboration on this subject. As Benjamin said, we are articulating the strong work in networks, and we hope this work to be articulated with the government, universities, and different institutions in the region. Thank you so much. Thank you. Thank you all for coming. We'll call you.
Bien. Parece mentira, pero estamos llegando.
Well, incredible. We're at the end. I'm just waiting a couple of minutes for people to take a seat. Well, incredible. Weeks and months elapsed here in Uruguay. Many things have occurred. I thank you all. I just would like to announce that we'll be able to enjoy a video that documents some of the activities and instances we have had of these 3 days of intense activity. Investment, innovation, implementation of policies and initiatives geared to transform the health systems in the Americas with a primary healthcare approach. This is an opening to build more resilient health systems, and for this we need to invest, innovate, and implement PHC. Alliance for Primary Healthcare. A round of applause for you. So when closing this meeting, we have Dr. Sean Fitzgerald, the Minister of Health, and Dr. Barbosa, thank you, Ernesto. And before passing on to the formal aspect, I wanted a round of applause for Ernesto and the whole team from PAHO present here, Uruguay, and all the countries up to Washington. It's been a great success.
On Monday, what we wanted to do was present for you and engage with you on looking at country experiences and bringing state-of-the-art knowledge on primary healthcare in the region of the Americas, and I think it's been a great success. Without further ado, I really wanted to also invite Dr. Jarvis Barbosa, our director, then, to come and give us a few closing remarks on this important event, the Foro Regional the Regional Forum for the Alliance for Primary Healthcare. Dr. Barbosa.
Good afternoon. Thank you, James. First, I want to really thank the government of Uruguay, specifically the Minister Karina Rando, present here, for receiving us in this beautiful country and city in this very important way and offering these very comfortable facilities where we have conducted the launch of the alliance and the forum for discussion at regional level on PHC. Tomorrow we'll have a national forum whereby the countries present will be able to become familiar with the Uruguay experience and the progress made to strengthen PHC. Thank you, Mr. Because I think that that is a specific demonstration of the reality of having all the countries working in a coordinated manner, learning from others' lessons in order to somehow progress in more harmoniously with PHC in the region. I also want to thank our partners present, the IDB present, the World Bank, UNICEF, CAF, and others participating here. I think from the start of the forum, we had this strong idea that without strong PHC, with a resolutive capacity, access of people would be sent to the more specialized levels, and we wanted a more resilient system. And one of the strengths is that we have learned from the experience of the pandemic, and that is why we're well coordinated with IDB and the World Bank. And it's a historical opportunity. I don't think we have had any occasion as such where we had this common aim in the organizations and countries. There's a great interest in countries. And when I meet the different ministers and vice ministers, strengthening PHC always comes up as one of the priorities in our technical cooperation. So we must transform this occasion into a well-coordinated action that may effectively work in a short term with this transformation of the health systems to guarantee access to people so that we can guarantee that the indicators we have change faster in the terms of persistence of some communicable diseases that should be eliminated as a public health issue, reducing the unacceptable burden of deaths due to non-communicable diseases that could be prevented with a strong primary care. All these systems we have known, teenage pregnancy, up to the issues we have in many countries because we lack, for example, access to mental health services. That was another topic that drew our attention during the pandemic, showing that we needed to change the manner how we organize access. I think that the alliance is very important, and the three institutions, PAHO, BID, IDB, and the World Bank, because we must underline that this is a process championed by countries that with technical cooperation have carried forward their proposals. Some have loan agreements with the banks, some are negotiating them, and we want to have this alliance to help us to balance the health systems. As I said more than once, it's important to have hospitals, new hospitals with modern equipment and trained staff. But if we don't have outpatient clinics and health centers throughout the region with good equipment and trained staff using new technologies to reach their goal of promoting access to people, the system won't be balanced and will probably have hypertension and diabetes consultations that are very high cost because they will be in the secondary and tertiary level where they shouldn't be and are a waste of the limited resources we have. So you have a major responsibility in this, and together with these three institutions, we'll work in a coordinated manner to change this. Second, during these days, you discussed this issue about investment, not only having more, but also to have better funding, quality expenditure in health, in primary health care, to reflect priorities in health for the countries and how we may have a more strengthened PHC. Innovation is another thing we debated during these days. It isn't only digital health. Of course, that is a revolution. There are many great potentials, and it's being already used to improve the quality of care and facilitate telehealth, telemedicine, and also with better use of resources, with teleconsultations, guaranteeing direct communication with the population, but also there are innovations in the manner how we deliver care and how we organize services that are people-centered with a multi-professional, multi-sectorial approach, not only within the health facility, but also within the community to reduce or eliminate barriers to access that are so important in some areas. We also debated the implementation, having a specific agenda, developing policies reflecting these principles based on the unique context we have in each country. We weren't speaking here about having a model top-down in the countries, but based on the knowledge and principles and good practices we have. It's very important to tailor this to the realities of the individual countries and also within the countries, identifying hurdles, bottlenecks, so that we may progress faster with strong primary care that is committed.
Here in this last session, I heard how they highlighted human resources, which is so important. If we don't have human resources who are qualified, trained, who can even be planned for the future to avoid crises of human resources, which we are already seeing, and if we don't change the training of our human resources, it will worsen over time towards 2030. So all these issues, I want to thank Uruguay once again for their disposition to share their experience, and it's important to discuss and highlight the interdisciplinary dialogue that we have seen. Our next steps, just coming to an end, I would like to highlight the cooperation, technical cooperation between the countries, between PAHO and the BID and the World Bank, because considering these lines of actions, we can accelerate these goals, which we are all sharing together to have a strengthened and renewed primary health care. And this will begin with priority countries, and by 2024 we will see many more countries, and they will invest resources and the whole technical cooperation that is needed to affect all countries of Latin America and the Caribbean. We also want to highlight some short-term priorities, the initiative to eliminate diseases, the levels, unacceptable levels that we have of certain diseases. In many diseases, we already have the solutions which are technical. We have tests, we have treatments, we have vaccines. So it is possible. In the process of strengthening primary healthcare, we can reach the most vulnerable population with greater speed and efficiency than it was possible in the past. Considering non-communicable diseases, maternal mortality, where we've seen a setback after COVID, even 2 decades back, we need to now pick up speed again and move forward to reduce them. Access to adequate sexual and reproductive services need to be considered as well. I would like to finally thank the commitment of each one of the countries and ministries of health, vice ministers of health, and their representations of all the organizations that are here present. On my behalf, as I said at the beginning, this is a historical moment for our region. I believe from here on 3, 5, 7, 10 years, we are going to be able to talk about this meeting as the one that kick-started this region, which is innovative. It shows global leadership in many issues. It's going to be the global leader for a new primary healthcare, which can advance towards healthcare and global healthcare and universal healthcare in all countries in Latin America and the Caribbean. And we'll continue this discussion. Thank you.
Bueno, muchas gracias, Dr.
Thank you, Dr. Barbosa, for these words, which guide us towards the future. And now, to conclude, I would like to invite the Uruguay's Minister of Health, Dr. Rando, to give her final words for all of us, and then to officially give closure to this regional forum. Thank you very much. Good afternoon. It is a great pleasure to give these closing words after 3 intense work days where we've considered such important issues for primary healthcare, but we have to recognize that this is difficult to speak after what has been shared by Dr. Barbosa, with such a comprehensive and clear perspective. I confess I won't be very original or very long, because I'm going to begin by once again thanking from the bottom of our hearts those who have made this event possible, the PAHO, the Pan American Health Organization, his director, and all the collaborators and workers who have been with us. I want to especially mention the mission in Uruguay of the Pan American Health Organization, Dr. Montenegro, and all the team who have been working and made this a reality and a pleasure. Really, it's been a pleasure to work together. I also want to thank other actors who have been present, the World Bank, the BID, UNICEF, CAF, and of course, I would like to really recognize the work of the Ministry of Health, who has also worked strongly led by Gabriela Gomez. Thank you. We have spoken a lot about primary healthcare in these past days, from the importance of implementation, the role of international collaboration, transformation of the systems, funding, and incorporation of technologies and digital transformation. considering non-communicable diseases, the perspective of PHC from the territory and equity, and also technical aspects like we just saw in the last thing about human resources in healthcare. All these points have considered the key elements of primary healthcare. These working days have made us think and reflect, considering that half of the population of this world still doesn't have basic access to healthcare, and Latin America is the continent with most inequalities in health. This doesn't necessarily encumber us because it encourages us to continue to work for this focus of health, which includes all the society, and we want to guarantee the best level of health and its equitable distribution to all of the population as soon as possible in this continuous process that goes from the promotion of health, prevention of the disease, treatment, rehabilitation and palliative care, and as soon as possible in our everyday lives. I want to thank the participation of all of you in this regional forum and the Alliance for Primary Healthcare in the Americas, and I continue to encourage you to work for this purpose. Thank you very much.